Okay, once again, we have a fairly packed day ahead of us. Lots of presentations and discussions and so on, so I think perhaps we should make a start. Hopefully, well, it looks like pretty much most people are here at least. Trust you had a good rest, a good breakfast, ready to face the day. Thank you again for your participation. Thank you for being here. My responsibility this morning is just to give a very quick recap of an overview to remind us what happened yesterday. A very, very good day yesterday, my opinion. Lots of very interesting talks by top-level people, very knowledgeable people that we could share information with, learn from, and also interactive discussions and polling to give guidance to our APMEN Vector Control Working Group. So before I start with a quick recap, I'd like to extend a very warm welcome to Dr. Sartak Das, who is our Chief Executive Officer of APMEN. He flew in very early this morning, and it's great to have him participate in today's discussions as well. Yesterday, we started off our day with warm welcomes from Dr. Mohammed Mukhtar, our chair for the APMEN Vector Control Working Group, and Amita, our executive vice president from APMEN APALMA, to welcome our excellent group of partners and stakeholders from across Asia Pacific, all our National Malaria Control Program representatives, partner institutions, and so on. And may I again thank all of you for making the effort and taking the time to join us here, to share with us your experiences and share your opinions on how we should best move forward. Then we had a series of presentations on outdoor biting tools, mostly newer kind of generation tools, ATSBs, ivermectin, cattle-administered ivermectin, outdoor residual spraying, also gene drive, which is more on the horizon out there, but it's up and coming, very promising tool that will make incisive difference in our ability to combat vectors, not just malaria, but many others in time as well. And those presentations formed the backdrop for breakout group discussion on which of these outdoor biting approaches should we experiment and trial with for potential application here in Asia Pacific. Some new tool that will help us to address this outdoor biting challenge that we're confronted with, not just in Asia Pacific, maybe specifically in Asia Pacific, but it's increasingly a major problem in Africa as well. So very relevant topic for discussion. After the survey, the group, in its wisdom, collective wisdom, decided that perhaps the most appropriate tool to evaluate at small-scale cluster randomized trials would be outdoor residual spraying, and that maybe Papua New Guinea would be an appropriate country for evaluating such an intervention. Then we moved on to discussions on public health entomology training and training platforms and the status of medical entomology on the planet. I made the plea earlier in the day, and I'm going to repeat it just to emphasize the point, because we really need your help, that we've circulated among our national malaria control programs a needs assessment that will give us a new kind of baseline of where we stand currently in terms of the vector surveillance shortfalls or capacity to address effective vector surveillance to underpin effective vector control in Asia Pacific by way of a survey instrument that is based largely on the 2018 needs assessment that was published in Malaria Journal, 2 separate publications, so that we can compare where we stand currently in relation to the 2018 findings. That would be a critical aid in enabling APMEN, among others, to evaluate how we can provide support, in what way, and on what issues. So I'd like to ask our National Malaria Control Program managers, please, it takes about 30 minutes to complete that survey. It would be a major help to APMEN. And we ask if you could, either yourself or delegate an appropriate person to complete that 30-minute multiple choice questionnaire. So after that series of presentations by Tirapap and various others, Freya and so on, we had another breakout group discussion with some very, very interesting findings. If my memory serves me correct, the collective wisdom of our national malaria control programs and other partners suggested that the greatest need is at field-level entomologists, field-level staff. That's where the greatest shortfall exists, that we should try and supplement. Specifically, these are among the questions that were raised, in vector surveillance skills by way of 2-week training courses, short courses, not long courses that take people away from their work that countries can ill afford to do. So short courses that countries can send their people to with minimum impact on program activities, specifically on vector surveillance, and specifically targeting field-level entomologists. That was the top priority coming from our National Malaria Control Program and other. This group is a cross-section of vector control experts across the planet. And your insights and wisdom is reflective of what the real needs are. So we're very grateful for those insights. In addition to those 2 thematic areas, we also had a few other very interesting learning presentations, update presentations. Leo Makita from PNG, who explained to us the current situation regarding malaria in Papua New Guinea. Thorough presentation there, and also Dr. Mohammed Mukhtar, who explained to us the probable climate change consequences as manifested by floods, major flood events in Pakistan, which resulted in malaria cases jumping from 2021, 300,000 annual cases to more than 3 million annual cases in 2022. And that in 2023, it's headed to 3.4 million cases of malaria. So dramatic consequences associated with global warming that is a warning to all of us that we don't know what to expect, and we should expect or prepare for not the worst, but crises situations, and how to deal with unexpected events like those climate change consequences that Dr. Mukhtar informed us about. So today is a learning day. We're going to sit back and enjoy a wide range of diverse topics, very interesting presentations, and then we'll end off with yet another thematic presentation or discussion led by Dr. Mohammed Mukhtar on discussing and trying to identify potential work streams, how to expand the value, the impact, the inputs that the APMEN Vector Control Working Group can make by way of work streams on particular thematic areas that we have to collectively suggest and identify and endorse, like RBM Vector Control Working Group, like several others. PAMCA, for example, also has these different work streams where select individuals, experts in particular fields of application can lead and drive particular interventions or approaches, strategies for malaria elimination. So we'll leave that to Dr. Mukhtar. It's going to be Dr. Mukhtar who will moderate today's events or our discussions, supported by Dr. Tang from Vietnam. And we are very grateful for your support, Dr. Tang. Thank you for being here. And thank you, everyone. We hope you enjoy the day. Thank you.
So thank you very much, Dr. Liu, for a very comprehensive review of the yesterday's activities. Now today we start our second day session, which is actually session 3, the learning premier talks and the bringing together the global mosquito control forums. The basic idea behind this session is that there are different working groups working around the globe, and every working group has the same objective, that to how we can get the maximum benefit from those working groups. So today's session, we want to bring together all those working groups so that how we can get the maximum benefit from these working groups by bringing together on one forum. So first of all, I would like to invite Dr. Tang to chair this session. And thank you very much, Doctor, for your acceptance of the chairship of this. So over to Dr. Tang.
Thank you, Dr. Muta, Dr. Liao. Good morning. So we start with the first speaker. I would like to introduce Dr. Kimberly Fornais, will tell us about the challenges posed by zoonotic malaria to elimination certification and the need for new policy guidelines. So, please, Dr. Kimberly.
Hello, can you hear me okay? Okay, great. Well, thanks very much for having me here. It's been a great meeting so far. So today I'm going to speak a bit about zoonotic malaria and some of the implications for malaria elimination and policy. So I guess one of the things to really highlight, I think many of us are quite used to thinking of malaria as a human disease, but there's increasing evidence that we really need to start thinking about this as a zoonotic disease. So like most human infectious diseases, there is quite strong evidence that malaria originated in wildlife populations. But really quite critically, what we can see is there's a number of zoonotic malaria parasite species that are circulating in different non-human primate populations across malaria endemic areas and can spill over into people. And so this is not just a problem that's limited to Southeast Asia, but we see emergence of malaria in South America and potentially some circulation in Africa as well. Can you hear me? Okay. So really, I think the key one that we wanted to speak about is Plasmodium knowlesi, as this is the zoonotic malaria species that really has the highest evidence of public health impact. So I think most people here are already quite familiar with this. This is a zoonotic malaria parasite that's normally carried by long-tailed macaques and other macaque species and transmitted by the Anopheles leucospirus group of mosquitoes. But really, I think some of the strongest evidence that this is an important public health problem has really come from Malaysia within the past decades. So certainly we've seen Malaysia has a highly effective malaria control and elimination program. This has brought indigenous cases of non-zoonotic malaria down to 0 since 2018. But we've seen this very marked increase in the numbers of human cases of Plasmodium knowlesi. So Plasmodium knowlesi is now the only indigenous cause of human malaria Malaysia, and this continues to have thousands of cases reported every year. So some of the kind of reasons that are implicated in the emergence of this type of malaria, we see very, very strong associations with human Plasmodium knowlesi risk and land cover change, so things like deforestation and agricultural expansion. Some of the very early reports that we saw of clinical cases of Plasmodium knowlesi were from East Malaysia in Sabah and Sarawak, and these cases had reported some types of forest exposure. Subsequently, in Malaysia, we conducted a case control study looking at clinical cases of zoonotic malaria and then matching these with healthy community-based controls. And this study identified both forest and plantation activities as increasing individual level risks. And subsequently, we've been working in Sabah, and we've seen at population levels when we do widespread cross-sectional surveys, deforestation and forest fragmentation are associated with increased risks of both exposure and infection to Plasmodium knowlesi. So we see that the highest risks tend to be around forest edges or areas that are being cleared. And I think one of the questions this raises is, with the zoonotic species, where are the reservoirs and where are the infected reservoirs? So this is some work we've recently completed doing a systematic literature review of all the surveys we could find across Southeast Asia that had tested non-human primates for Plasmodium knowlesi using molecular methods. So this is 148 unique surveys of over 6,000 non-human primate species, predominantly long-tailed macaques, but some other macaque species and other non-human primate species. Most of the data has actually come from West Malaysia, so there's still some key evidence gaps in this. But one of the things we can look at, even with some of the huge uncertainty around these very small numbers of non-human primates that have been sampled, is there are significant spatial heterogeneities in the infection rates within the wildlife reservoir. So if we look at Borneo, which reports the highest numbers of human cases, this also has the highest rates of infections detected in macaques. And these are also associated with forest metrics. So the areas that are reporting the highest infection rates in macaques are often in these fragmented forest areas as well. And then, of course, this also raises a lot of questions about the vector ecology. Our colleagues in Malaysia at the University of Malaya and University of Malaysia Sabah have been working quite extensively in this area to look at what vectors are incriminated in transmitting this disease. And this is a picture, I think, that's quite similar to many places across Southeast Asia, where we see these are predominantly outdoor biting mosquitoes, and these are biting in early hours. So these are times and locations where people are not protected by bed nets and are at risk for transmission of this particular disease. The other thing that we see, which is particularly pronounced, is this association with habitat type. So for many of these vectors that have been incriminated, we find very, very low densities in intact forest areas, so in primary forests. We find an increase in some types of agricultural areas, but really the highest vector densities are predominantly in secondary forests, so in these very disturbed forest edges, which seems to be really driving transmission risk. I think one question this raises is that when you see this very dramatic increase in the number of cases, is this a genuine increase in cases due to these factors around land use change, around changing contact with vectors and macaques, or does this actually represent a change in transmission? So are we starting to see that this is becoming a non-zoonotically transmitted disease? So we do know this is possible. This has only been showed once. There was one study in the 1950s in the US that experimentally infected prisoners, showed they could infect Anopheles babesiosensis, and this was used to infect another person. But really, this is only one data point, and none of it has been shown naturally. We've done quite a lot of work on this to see what evidence we have that this is actually occurring in nature, because we know it's possible. And both systematic literature reviews and mathematical modeling of case data from Malaysia found no evidence of widespread non-zoonotic Plasmodium knowlesi transmission. So we do think it's still predominantly driven by spillover. And if you're interested in any of these work, these are some of the papers that we've submitted, we've published around this. I think one thing to also highlight is that we really focus on Plasmodium knowlesi because of the public health burden, but there are a number of other zoonotic malaria parasites that are circulating across Southeast Asia. Both these are all cases that have been identified in humans, and these include cynomolgi, inui, fildi, and other zoonotic parasites. So there's really no evidence that any of these are major public health problems at the moment, but okay, try this one. But yeah, certainly we wouldn't have thought Plasmodium knowlesi was a major public health problem several decades ago. So these are areas where we do need to monitor. I think the other thing that's worth highlighting is this is not a uniquely Southeast Asian problem. We work quite closely with colleagues in Brazil who have been doing a lot of work on different zoonotic malaria species. So these two maps show the distribution of Plasmodium simium and Plasmodium brazilium, which are circulating in wildlife in South America, and also spill over to call human cases. So we've seen a number of human cases appear in these areas, particularly in areas that have eliminated other malaria species. So there is increasing evidence that this is a global problem. I think one thing that has really raised this, as many people are probably aware, we saw a change in the elimination certification guidelines by the WHO last year. And this specifies that certification of malaria elimination requires the elimination of the 4 main human parasite species: Plasmodium falciparum, vivax, ovale, and malariae. And certification might be granted to countries where cases of other Plasmodium species are reported if this risk to humans is assessed as negligible. So this is really the first time we've seen these other malaria species included within elimination guidelines. And I think some of this really raises some of these questions that go around, kind of wider questions about when a disease is actually a target for elimination and when elimination is really a practical approach. So many people are probably familiar with the Dahlem criteria, which were set up in a workshop in 1997, thinking about some of the biological, economic, operational, and social factors that determine whether or not it's worth prioritizing a disease for elimination or eradication, and how feasible this is likely to be. And kind of one of the kind of key criteria that came out of this was that it's very difficult to eliminate zoonotic diseases without either highly effective interventions, such as a highly effective vaccine, or extermination of the reservoirs. So certainly when we look at zoonotic malaria, this is not necessarily the case here. I think the other thing that's really worth mentioning is that there is a pathway to think about how you move forward with elimination, even if we don't think elimination of the entire disease is practical. So certainly WHO has pathways for looking at elimination versus strategies to eliminate a particular problem as or eliminate a disease as a public health problem. So thinking about what is the right pathway and what is the right approach or goal to target for these type of zoonotic malaria species. And so I think certainly we've seen that zoonotic malaria raises a number of challenges. We do have unprecedented rates of environmental change, so it's unlikely that this problem is just going to go away, and we might see it appearing in new areas. Potentially, we have some impact of changing levels of immunity as other malaria species are eliminated. We don't have any evidence, but we have seen an increase in zoonotic malaria cases in areas where there have been other species eliminated. And I think really the key point and a kind of key research priority for this group is the fact that we just don't have any current control measures that are shown to stop zoonotic malaria transmission. So there's really kind of a limit to what we can do to actually control this disease. So really, I think there's a strong need for innovative surveillance and control measures to think about how we address something where there's a clear wildlife reservoir. So we've been thinking a lot about what the way forward is. These are my personal views rather than the views of any policy organizations. But really, it's kind of becoming increasingly clear that we need to really think about how we redefine malaria elimination. And and think about new approaches where we can act for malaria elimination certification, where we actually separate out pathways by transmission modes for zoonotic versus non-zoonotic species. Without any effective interventions that target the reservoirs, it's very, very unlikely that zoonotic malaria can be eliminated. So really the goal for this should be thinking about how we can eliminate zoonotic malaria as a public health problem. And that, of course, raises the question of what is the public health problem and how do we define some of the thresholds for this. And kind of finally, I think there's a wider question about thinking about what types of surveillance data we need to actually monitor zoonotic malaria. So we certainly need to understand the burden of this disease, but also to collect genetic and epidemiological data that allows us to assess whether we have any evidence that transmission patterns are changing. So some of the thoughts that we've kind of put around this, these approaches to policy and some of the needs are in this paper here, if anyone's interested in reading further. So with that, I will end and just thank the many people who have been involved in this work. And please feel free to get in touch with me.
Okay, so thank you so much for very interesting presentation from Kim Lee. And next for the second presentation, I would like to introduce Amy Morrison for the presentation, Evaluation of Kyrostec, a low-cost and effective artificial blood feeding device for mosquitoes. So please.
Hello everyone, my name is Amy Morrison and I'm speaking with you from Iquitos, Peru, where Elvio Astete invented our artificial blood feeding device, Caserotec. We thank Leo Brack for the invitation to participate in this conference, and I encourage you all to download our article in the August issue of PLOS NTD, where all the details you need to build your own Caserotec are. I don't think I need to talk too much about the reasons we need artificial blood feeding systems, but after years of using sausage skins, condoms, fighting with water baths, and a final blow with Ayacook not allowing us to use our free-range chickens to feed our mosquitoes, I was ready for an alternative. As Elvio tells it, sometime in 2014, he scribbled the original designs on a napkin in a local bar and had Angel start building prototypes. The device is homemade in every sense of the word and has been perfected by trial and error and a few key suggestions along the way. Because Elvio is a government employee, I have to put this disclaimer up here and let you all know that the opinions expressed in this presentation are from the authors and not the U.S. government. In reality, Caserotec comes in multiple sizes depending on the local availability of plastic cups in your area. We like the urine cup design for our needs, and those are the measurements we published. But just about any plastic cup design will work as long as there is a lid with a small lip on it. And this is where the blood will actually collect. You need a 10 millimeter diameter plastic tube, styrofoam coffee cups, and somebody who is good with a glue gun. You cut 2 10 millimeter holes in the lid and at the bottom of the cup and attach the plastic tube flush with the lid and out the bottom of the cup. You cut another hole in the bottom of the cup to pour water in, and then line the cup with styrofoam. The only other items you need is Teflon's plumber's tape and the ability to boil water. We will now show you a video on how to use Caserotec. Okay, so now I'd like to take you through our demo video. And as you can see, the first thing you have to do is boil water. And you're going to put that to the side and measure the temperature. You also need to collect blood in a tube with some sort of anticoagulant. We just do that at a local butcher. You can see there's your supplies. Again, many different sizes. But the key step is putting the plumber's tape or the Teflon tape over that little lip. And we have somebody demonstrating that process. And you just keep stretching and stretching and stretching. And you can see there's a little space below where when you turn that over, and you can tape that shut if you like. Make sure your water is at 40 degrees centigrade, your boiled water. And we put about 40 mLs, as you can see there. And this is going to go into that compartment where you have the big hole in the bottom, and it pours into the compartment lined with a styrofoam cup. I was wrong, it takes 80 mLs. Just fill her up. And then you just can put it right on the top of the container. We put about 2 mLs of the blood with additive down the tube, and it's going to collect right there on that small lip. And the mosquitoes feed very happily right straight through the Teflon. We originally did it with parafoam and used the plumber's tape to kind of keep it in place, and then realized that they were just as happy poking through the Teflon. You can see lots of fat and happy blood-fed mosquitoes. We find they feed very quickly. So we did 3 experiments, 2 with Aedes aegypti and 1 with Anopheles darlingi. Just to show you some of the highlights here. Starting with Aedes on the right panel, you can see results comparing the feeding rates at baseline and weekly after that. On top, we only exposed mosquitoes for 30 minutes, and you can see that Caserotec did better. These were head-to-head comparisons exposing 100 mosquitoes with each device. Caserotec is shown in orange. In the bottom graph, the difference was that Aedes were allowed to feed for 1 hour. Under these circumstances, feeding rates were about equal across the devices, with the exception of Hemotec, which performed badly during the initial feed. On the left panel, we compare egg production per female, and you can see that Caserotec did as well or better than the other devices. In conclusion, Caserotec is easy to make using local materials available in low-resource environments. The cost was about $5 per device. And we've used this effectively in our laboratory since 2015, and we're able to produce about 500 females per week that we used in direct feeding experiments. Caserotec has comparable or better feeding rates, egg production, and survival rates compared with glass feeders and Hemotec feeding devices. For Anopheles darlingi, all feeding and fitness parameters were comparable across devices. And finally, the scalability of Caserotec for mass rearing of mosquitoes or for work with pathogen-infected blood would require some additional testing. Thank you very much for your attention. We'd like to thank Alfonso Vizcarra for helping us make the feeding video, and also others in the lab who helped put this all together. Thank you very much.
Okay, thank you, Amy Morrison from University of California. And for the next presentation, I would like to introduce Dr. Susan Ragos from National Institute of Malaria Research, India, with the topic, how important is Anopheles Stephen see in India, and how does India combat with it? Please.
Good morning, everybody. I'm privileged to have here this morning very important topic, Anopheles diffensi. It is the talk of the, now this decade, because this species is expanding its horizon and then creating a lot of public health problems. I am working for almost 4 decades in this organization's National Institute of Malaria Research, and this year I was elected as the fellow of National Academy of Medical Sciences, which is the most important, medical body in the country. So my talk will be just brief history, that this Anopheles diffensi Liston, he was the British medical officer in 1901. There is a village called Ilachpur. Now it is called Ilachipur. So it is just 750 kilometer little eastern of Mumbai, Maharashtra. And it is generally called Asian malaria vector. And this is the original article I could find published in Indian Medical Gazette in 1901. And then they have 3 distinct biological forms, Anopheles diffensi. It has got based on the egg-rich numbers, because there are these variants, these forms, they behave differently in their feeding behavior, their vector competence, and all these factors. And the thing is that recently there are many articles I can track that molecular identifications not yet been certain. My junior colleague published in emerging infectious diseases concluded that is not possible. But some work now being carried out in Bangalore, and my wife is working on this. There are 3 variants now growing in Tata Institute for Genetics and Society in Bangalore. And all the 3 variants, and very distinctly, and they're distinctly working on how this can be, used. Now you can see at a glance that it has been invading in all the east part of Africa. Then now it has been reported in western part, Nigeria, Ghana, and recently WHO has Eritrea also now they are found. So this is very, very fast invading species now. If you look into the history of Indian context, you can see that, pointer, is there pointer? Okay. You can see that, from this distribution pattern, it was just 1927 to 1958, because 1958 was malaria eradication program started, and then post-eradication 1959 to 1999, there are a lot of places, it is appeared might be due to this, insecticide spray of DDT and all. But now the thing is that, 2015 onwards, again, it has expanded, and might be because of the resistance of insecticides. And the thing is that it was reported also from northeastern states, but not now it is not. I was discussing yesterday how this species disappeared from this particular area, because here is the dirus, minimus is the vector. So how scientists, we should find out why they have disappeared. And the thing is that larval habitat, if you can see, they are heliotropic, but heliophilic and heliophobic, because the sunlight they sometimes like, they sometimes don't like. And I have seen that adult collections are sometimes difficult, but if you find out a proper timing, then it will be very important. The most important factor is that they have got a called xeric form. Xeric means desert forms like Africa. They have got xeric form. Even slow, I was just following from African context that and I was talking to many scientists working in those areas. They say that they are just clueless, and everywhere this mosquito is breeding. I was attending in vector control working group meeting in Ghana, Accra. They are also from Sudan, one scientist talking to me that it is breeding in 3 holes. I don't know whether to confirm that. So biting time is, dusk or at night. The problem of bed nets, many places, they are biting hours are early evening, and that becomes the biggest is a problem. So they are primarily endophilic but exophilic in warm conditions. That another problem, because tropical conditions are now warm conditions, so they can also exophilic, their feeding behavior. So that is the challenge. Now we have to find out the, the biology of this particular species in local area, and then determine what strategy we have to go for that. So we have done, in Bangalore, I base. So this will be the greatest example of geographical reconnaissance mapping if you do in urban areas. The thing is that in India, this malaria vector is urban malaria vector. Unlike Iran, it is Mysorensis, they say it is a rural vector. Even Dr. Mukhtar also can support me. In Pakistan also, I think this might be Mysorensis, and because there is an article from Iran scientists that all the 3 variants of especially Mysorensis, their vector competence are almost equal. So there is no question of vector competition part. So, but if you do a proper planning for this thing, you can find out how this, going to help us for these aspects. If you look into our Indian context, that urban malaria scheme was launched in 1971. Government of India, and covering 142, almost 143 million people in India, 131 countries, towns, cities, and where 10 to 12% malaria was contributing. So now the thing is that urban malaria scheme, the objective was to prevent deaths due to malaria, reduction in transmission and morbidity. So that was the main objective. And norms that towns should have minimum population 50,000, annual parasite index should be above 2, and then civic bylaws to be prevented. And civic bylaws plays a great role in containing this particular mosquito. The major thing is vector control is source reduction, larval source management, use of larvaceous fish, larvicides, space spray, minor engineering, habitat modification, and legislative measures. If you can see, this is the distribution pattern of the map in India, where are the towns located. And you can see that Anopheles stephensi transmitted malaria in India, and of course now for last 5 or 6 years, 7 years, it has decreased, but still certain pockets, they are struggling, like Mumbai, and I'm basically from Kolkata, so Kolkata city is also facing a lot of malaria outbreak currently going on. So these are the problems now facing from this. And again, I just to see that which are the states having 31 towns and cities. And this is a source from National Center for Vector-Borne Disease Control. And now the thing is that recently, 2023-27 urban malaria national strategic plan has been chalked, and then objective is malaria transmission risk reduction through IBM, integrated vector management. Objective 2, increase the access to diagnosis and treatment with the focus of construction sites and industrial estates. That is the biggest problem, constructions going on in almost all the towns and cities. And this is actually the challenge, because there are a lot of migratory populations coming from the endemic areas to the cities for their livelihood and all, but they are not protected. What I can give example in the city of Mangalore, what I am working, I can tell you how we have effectively doing this work. Now, enhancing awareness, the malaria elimination, promote community, NGOs. NGOs played a great role in the civic society bodies, because they are associated with a lot of groups of people, prominent people, and public-private partnership. I think this is the CSR fundings and roll-up industry list. So another is the framing and introduction of model civic bylaws. I think the Mumbai bylaws 1888, since then it is Mumbai bylaws, they call Bombay bylaw. And that bylaws has been implemented in many cities because since in India, health is a state subject. So the state to take the decisions. Another problem in India we face that all the towns and cities under the urban department, not the health department. So decision has to be taken by the urban department. So there has been breached the gap that we scientists or we the policymakers tell the urban department that this is your problem and you should address this issue like this. So building bylaws, it was imposed in many towns and it is really effective. Sometimes the town planning office, they suspend the license on the builders if they don't follow the guidelines. And it is really effective. Now the thing is that I have given just a specific intervention through IBM. You can see that where are the locations and the major, the problem wells. Wells actually the ecological niche, this mosquito they breed. If you target the wells, and I think, and this tape well like Beris or Taka in the desert area, in India, the western part, Rajasthan, and all these places, they are the real place, and then it is a like Barcade in Africa. They are the same similar water reservation processes. So these are the things, and what the local body can play, elected local government, panchayat, India has that panchayat institutions, and they play the major role in policy decision for implementations, not the policy thing, implementing the program and municipal corporations. These are all independent bodies, the elected government, self-elected governments. So, and then local is IBM is PWD, Public Works Department, Central Public Works Department. These are the departments, they are the responsible for the constructions of the roads, buildings, government buildings and all. So these are the bodies, if we take along with them. And one thing I can tell you, never use gambusia in these areas because gambusia is not the fish we are of choice, but guppies are the choice. I can tell you why it is so. Now these are the, some building sites, potential building sites. You can see that cement tank, unfinished buildings. Suppose this building is somehow not completed. If it is completed, it's fine. If it is some legal tangle are there, the building will be lying idle for several years, and this become the hub of the Stephen Sai building. And curing water, then this type of, building sources. It's a very beautiful design over the tanks, but you can see Stephen Sai is the house for this kind of situations. These are the fountains. Now the problem is window sets, box window sets. I don't know why they make without any pipe to excess water to come out. So these are the places, huge breeding of Stephen Sai. Even this plastic barrel, I think this is the one of the major culprits throughout the world, I can tell you. In Africa also, I have seen, these are the plastic barrel. This is also Aedes and Stephen Sai. And these are the Aedes and Stephen Sai, these are all Aedes and Stephen Sai, they co-breed. And this is the biggest challenge we are facing right now. Now, some action plan has been formulated in India about the 7 action plan. It was by our institute, and these are the points, action plans by the government, inter coordination. You can see the wells, the overhead tanks, mosquito-proofing overhead tanks, and this is the guideline. It was made by our institute, and I think it was made because of Chennai city, and Chennai was also a big problem, but after implementation, the malaria cases and the prevalence of Aedes, Stephen Sai has gone down. So these are the certain points, if we can take forward, I think others to follow for this control of Stephen Sai. While I was working in Mangalore city, you can find that how this wells, fountains, but the masonry construction sites was the big problem when we put up these slides in front of the commissioner of Mangaluru. They took up immediately the civic bylaws, and after that, cases has gone down drastically. And this is the thing I was telling you, that biting time is very, very important. You can see it starts from 6 o'clock in the evening, and and then peak by 10 o'clock, 11 o'clock, and then another bite from 3 to 4 o'clock. So these are the points we should consider. Otherwise, any intervention measures we do, it will be failed. So if we talk of LLIN, if we talk of IRS or whatever it may be, that's what it is not possible until you do that. Now, we have done one beautiful, handheld GIS-tagged digital surveillance in the city, and it has been published two back-to-back publications we have done in Malaria Journal. And this is actually a real-time organic surveillance mechanism, handheld device. It is given all the health workers, diagnostic center, and each and every cases are tracked with this device, and there's 137 formulation. Like if the case is diagnosed, it is going to for treatment team, and then also that is flagged to the vector control team. So within 7 days, the vector control are taken care of in this manner. So now you can see when we have introduced in 2015, now cases have just crashed. I was told in 2022, 168 cases. This is the city in Karnataka giving 80% malaria still, but the cases have gone down drastically. And now in the state of Karnataka, 2022, when I joined 94, it was about 0.3 million cases. Now it has gone down to less than 300 cases. So 0.3 million to 300 cases reduction, it has been done. And that is another story I can tell you. And it is possible. It's not that, not possible. So elimination versus eradication, we are talking, but it is really, really possible. If you can see that this EPS beats in unused wells is very, very effective. And my director, Dr. V.P. Sharma, introduced, and I think Professor Chris Curtis from London School, he was the person introducing this. I think Michael, you might be knowing all these stories. So this is very effective method of this thing. What happened? Okay. I don't know. Just check. But I think, that's what I'm telling as a scientist, we are working along with the government, and whatever the results are coming, I was telling them that it will be. Now, very important thing that I just say, my junior colleague from my institute has published in Malaria Journal 2021. This is actually the, called TACA. And you can see they have just repaired and changed these leads. And there was 94% reduction in the vector and the disease. So a small intervention with big impacts. It is published in Malaria Journal. Same thing like, in Africa, if you talk of in Africa, same kind of, water reservoir, rainwater, in desert area. Just take care this thing, I think the game is changing. So change maker, process. Again stuck. So now the thing is, you can see how this process came, and there are many fishes I have given, but these guppies, I can tell you, I was talking to Leo, don't use these colored guppies, because these guppies are genetically modified for killifish. Yeah, so that is the thing, and now from there, this study was audited by the CAG, the highest body technical wing, and after that, we have given fishes into many, many states like Assam and all, and how, see, this is the process. If you do proper fish release program, you have to acclimatize in the local conditions, and you can see the guppy movement with the local organizations. This is the health minister of the government of Karnataka. They have made a van like this as a public awareness, and it is really impactful events. So now I think September issue, APMEN, they have published, mentioned the best practice, Mangalore, Karnataka, our work they have mentioned recently. And the challenge is, it is an invasive species, adaptive species. Only thing is the LSM, but there is a lack of confidence in LSM. We have to go for that. Now the more of urbanizations will come, then in India, our urban malaria scheme is done in the health department, but urban department also to be involved. Lack of expertise handling the situation, inadequate limited funding. Now we have many options but limited actions. So that is the thing I just gave. Future potential, that there are a lot of, additionally flagship programs by the government going on, like, Swachh Bharat, Clean India program, the National Health Mission program. I think we have to tag with all. It will be cost cutting. Not only that, your work will be very effectively done. Only being the scientist, I think, we should just tell that how to do it. I think we had published one article in APMEN 21 March issue of newsletter where Leo and me has shared that how Indian experts can, help African situations, and that is the thing. So now let's join hand together for a malaria-free world. This is my message. I think it is doable, and I am telling PAMCA and African people, take our advice and rest assured that there will be no problem of Stephen's eye. Don't worry about from where it has come. I am telling that it has come in Africa. Now we have to control or eliminate. How to do it, we are there. Thank you.
So thank you very much, Dr. Susanna, for very comprehensive presentation. Thank you so much. So now we move from India to Australia. I would like very much to introduce Dr. Amanda Murphy from James Cook University, will tell us about prognosis and need assessment in Asia Pacific. Over to you.
Thank you so much. Lovely to see you and everybody again at the APMEN meeting. It's been a few years since I've attended. I'm very happy to be back. I'll just start to share my screen. And please let me know, can you see the correct view?
It's good. Thank you very much, Amanda. Great to have you on board.
So my name is Amanda Murphy from James Cook University in Australia, and today I'm very pleased to give you an overview of a project being led by our university we call the PACMOSI project, or Pacific Mosquito Surveillance Strengthening for Impact. I thought I would start just with giving you a bit of context in terms of the region that we're working in. So the Pacific is a very broad geographic and cultural area, which we generally tend to split up into the three sub-regions: Micronesia, Polynesia, and Melanesia. And there's an extremely wide diversity across the region of mosquito-borne diseases and capacity of vector-borne disease control programs to detect and response to these diseases. What the region does tend to have in common is that most of the countries are small island nations or collections of many small islands. And so there are similar challenges that are in common, but there's also, as I said, much diversity. And on this slide, I've also in green just noted some of the institutions that we're working with in the region. There's quite a few institutions with good expertise in vector surveillance and control, who through this project we have tried to bring together in collaboration. A little bit of background on the vector-borne disease burden in the Pacific. So arboviruses are quite prevalent across the whole region and have been increasing in terms of the magnitude of outbreaks over the last 10 or more years. You do have all the serotypes of dengue circulating, as well as chikungunya. Zika is still around. That's recently, in the last few weeks, new cases reported from the Solomon Islands in conjunction with dengue and also malaria, all at the same time. So there's multiple challenges in the region. Just to touch briefly on malaria, there's only 3 countries where malaria is endemic in the Pacific: Papua New Guinea, Solomon Islands, and Vanuatu. And although the incidence has been generally declining over many years, like other countries around the world, there have been some upsurges as well in recent years, and certainly many challenges to eliminating, as you're all very familiar with. So our program covers all the mosquito-borne diseases, so malaria, arboviruses, and anything else that is of concern to the countries. The main other one is lymphatic filariasis that is in quite a few countries as well. And so our project is really aims to bring together a consortium of partners in the region to support countries of the Pacific to build their capacity to combat all mosquito-borne diseases. We do tend to have a focus on Aedes-borne diseases just because that they are the most prevalent problem in the region, but the program is to build capacity across all vector surveillance and control. And our approach has really been to try and look at sustainable and locally appropriate approaches to improve that capacity. So not necessarily bringing in the highest tech solutions if it's not possible for the countries to sustain them, looking at what the countries already have and trying to see if we can do more with that existing capacity. Sometimes it's really just about targeting better. This is an overview of the different arms of the project. It is quite multifaceted and aims to comprehensively build capacity across a range of the areas that you'd imagine would be needed to conduct really thorough vector surveillance and control. So when we first started the project back in 2020, the first thing we did was a needs assessment across all the Pacific Island countries to see where they were currently at, what the status was with what kind of infrastructure they had, what sort of diseases they had, and what methods they're already using for surveillance and control. We are planning to publish that at some point, but none of us seem to have time to finish writing it up. But we'd be happy to share that. I think we have shared some of that with some of the colleagues in APMEN. One of the other main activities that our project focuses heavily on is conducting training programs to build the knowledge and skills of the staff in the vector-borne disease control programs to be able to do surveillance and control. And that's a combination of online training and in-person training workshops. And we're also really trying to get together sort of the South-South peer support and mentoring programs as well, even if informally. So I'll talk a little bit more about that, and I'll just briefly touch upon the other aspects. So trying to encourage digitization of surveillance and control data and reporting of that data, mainly to save time and make it easier for control programs. And expanding surveillance and control in a practical sense. So that means we actually send surveillance and control equipment to the countries. Many of them don't even have traps to do trapping, to do basic surveillance. So one of the first things we did was just send everybody some traps to get them started, and basic things like microscopes to do ID and all of the basic lab equipment that you would need in a basic entomology lab. So that's another arm. And then finally, we also support countries through small grants to conduct operational research as needed to fill knowledge gaps and things like that. So I'll just briefly go over each one of these now. Just a brief snapshot of one of the outputs of the needs assessment is shown here. And that's where we did ask about both Aedes and Anopheles capacity. This is just showing the responses from the countries when we asked them what kind of control methods that they currently use for Aedes control. And as you can see, they're quite diverse, with most countries very heavily reliant on using larval source management and cleanup campaigns and things like that, or larviciding. They're really the staples. Hardly anybody doing any IRS across the region. The malarious countries are using the ITNs, not many other countries. And, you know, very variable levels of fogging or misting, both indoors and outdoors. So that's quite variable, but usually only in response to outbreaks, not really done sort of routinely at all. And heavy reliance on donor assistance to conduct a lot of those activities. A lot of ministries are not funded. It's not a standard budget line item for them to be able to have chemicals to spray. So often they wait till they get an outbreak and then they ask a donor to buy them some chemicals and then they eventually do the spraying, which, as you know, as you would imagine, is not particularly timely. So a lot of the work is sometimes just about trying to improve timeliness, planning and targeting of the existing interventions. And yes, a few countries do have the Wolbachia as well. So moving on to the training, this is an overview of the topics that are covered within our online vector surveillance and control course. This is easily accessed through our website. You simply go to the website, click on training and register, and you'll get a little link. It's all free. Anybody around the world can do it. We designed it specifically for the Pacific, and it's tailored to what we believe their needs are, and even visually, the way it looks and the pictures and things like that, it's all very Pacific focused. However, the content is all according to standard best practices recommended by WHO for mosquito surveillance and control. So anywhere around the world, it would be relevant, and anyone from any country is more than willing to register and conduct the training if that would be useful. The benefit of the online training is that you can access anyone in any country, as long as they have internet access, can get some basic training. We thought that was important, as opposed to of course, in-person training is important as well, but you only get, one or two people, whereas the online training can be given anywhere, anytime to a much wider number. So here is just a bit of a preview. We try to make it very, very visual, very interactive, lots of videos, lots of, pictures and interactive exercises and test yourself questions. So we hope that it's very engaging for our audience. And so that's just to give you a bit of an overview of what it looks like. And also on the website, to go with the training and to complement it, we have developed a range of resources that you can download through the resources tab, which we have developed. For example, a mosquito key was needed for the Pacific because there wasn't one already. So we made one. We've developed various guides and SOPs for trapping, just to explain the basics to people, and that's all freely available online as well. To complement the online training, we have done a series of face-to-face workshops. Because of travel restrictions related to the COVID pandemic, we've only been able to do 4 so far, but they've been very successful. We've done them in different countries and covering different topic areas to do with vector surveillance and control. And those have also been a great opportunity, because sometimes it's the same people going to the trainings, as you might find with your APMEN trainings. People do get to know each other and start even a bit of informal networking, chat groups and things like that through the training. So that's been another great benefit. So aside from training, the other types of support to be able to expand the actual vector surveillance and control activities have included shipping equipment, as I mentioned. So we've sent boxes and boxes of microscopes and lab gear to every country just to give them the basic setup. And we are also in the process of shipping some sprayers to all the countries as well, for IRS and for outdoor harbourage spraying. That was done to support one of the recent trainings, which was on IRS and ORS. We wanted to really try and give the countries the chance to put the skills into practice straight away. We've also held a number of in-country consultations, aside from training, on other aspects of vector surveillance and control, like strategic and operational planning, for example. That's one of the arms of our work, and there's 4 countries in particular that have really engaged heavily with us in wanting to develop national strategic plans for mosquito-borne disease control. Most countries in the Pacific, we found through the needs assessment, did not have any plan or SOP or anything in place for Aedes-borne disease outbreaks. So in response to that, we offered support to develop national plans and SOPs and things. And in those few countries, we've now got the first plans ever for mosquito-borne disease control, which is fantastic. Almost there. The second last thing is data management support. So we've been working with partners from a company called Beyond Essential Systems. They're a Melbourne-based company, to develop mobile-based data collection apps for vector surveillance and control. And so we worked with them to develop the form shown on the left that people can bring up on their phone and note where and when they set a trap. And then later on, you can go in the lab and put in all the species after you've done your ID. And that's automatically linked to a visualization platform shown on the right called Tupaya. It's the name of it, named after a famous Pacific explorer. And what we hope this helps to do is take the work of data analysis sort of out of the challenges with that, to assist with those challenges, because we've found that most vector-borne disease control programs struggle with having a person who has the skills to actually analyse all of the surveillance data and then generate reports and regularly report on it. And so this is one of the other aspects that we're working with countries who are interested on. And finally, the last aspect to talk about is the little grants that we've given for operational research and also for citizen science as a way to try and strengthen the community engagement aspects of surveillance and control. So there's various grants that have been given to different countries. And also, I'm just showing an example here from we've got a multi-country research project underway at the moment, which aims to just study which types of traps are most feasible for vector control programs for Aedes, and just showing some preliminary research from one of the countries there, from one of the countries on what types of traps they're finding. And this is using the Tupaya app as well. So they're trialling this new Tupaya app through doing the research as a way to test whether it works for them in their program. And we're getting some early results from that, which will be nice to see as well. And that's it, just to sum up. As I said, we're a regional consortium of partners all working together on mosquito-borne diseases in the Pacific. We've got lots of different aspects to the project to try and comprehensively address the capacity needs of each country. And we're really hoping to empower everyone across the Pacific to not only be able to implement more effective vector surveillance and control, to have it be locally appropriate, and also to be able to share their experience and best practices between countries. And on the note of sharing, very pleased to engage with the APMEN network, and to be able to share with each other as is useful going forward. So thank you again very much for inviting me to give an overview of the project, and just to thank and acknowledge some of our partners there and the Pacific countries on the screen. Thank you.
Thank you so much, Dr. Amanda Murphy, for the very informative presentation. So we already have 4 fruitful presentations. I think enough food for talk for breakfast. So I think we need some refresh. Now 9:47. So we will come back for 10:05 for next presentation. So thank you so much for the attention. Thank you, all presenter. we are refreshed and we continue. I'm happy to introduce Dr. Mohammed Mukhtar from Pakistan, the director of the Directorate of Malaria Control. He will tell us about addressing the vector monitoring need of Pakistan, the new state, the art of laboratory facility. So over to you, Dr. Mukhtar.
Thank you very much. Very good morning. Again, I'm Mohammed Mukhtar. I'm Director, National Malaria Control Program, Pakistan. And today, this presentation will address the vector monitoring surveillance needs of the Pakistan. But sometime I remove the word Pakistan because this is the need of every country. So I will make some general discussion on what is the need and how we can address these vector control, monitoring, and surveillance. Sorry for this very busy slide, because yesterday I heard a lot from doctors from India. He was talking about a lot about the Stephen size. So I have to make this slide, which is actually the combination of this Indo-Pak subcontinent, and it is almost 55 years data of the Pakistan. Most of the data is published. So I have some enlisted Anopheles species, which are major, and as I yesterday told, that Anopheles culiaceae is a major malaria vector in Pakistan, where it breeds. So this column was published in 2004. If you look at this, I will just read the last line, that it is totally is a purely clean water breeder species. But when we compare this species with Stephensii, because there are a lot of discussion, the Stephensii has been showing a wide range of tolerance to different physiochemical parameters of the breeding side. This species can breed in a highly polluted water. We reported in 2007 first time that first record of Stephensii breed in Pakistan, highly polluted water, like in a septic tank, domestic raw wastewater. And in second column, resting habits, if you look at the culiaceae is 100% endophilic, but no exophilic report from the culiaceae. But if you look at the data is up to 2017, because in 2018, when we start distribution the bed net on large scale, there was some change in the resting behavior of these species, and the culiaceae also showing some resting behavior outside the. So after 2018, there are some record that this is exophilic as well. Resting places, purely sleeping room, where the human population are there, and the animal share some population. And feeding behavior is anthropophilic. Mainly it feeds on the humans, but it also has the zoophilic, because there are some animal shared population was also there. Biting times is very important. Early and mid hours of the night, but again it's a 2017. 2018 onward, we start reporting its feeding behavior much early evening, like 5 o'clock or 6 o'clock particularly. Then its seasonality. If you look at it has a unimodal, it has only peak after the monsoon season. And the fluctuation, unimodal means that it has only one peak season in a year, and this is a primary vector. And same is Stephensii. If you look at the Stephensii, is a purely endophilic, but after 2018 there are many records that is going outside. It has no feeding outside the houses, and it's a secondary malaria vector. And that's a pulcharimus. Here is a pulcharimus. It is 2017, and we also said is a suspected malaria vector in the central Punjab. But yesterday I told you a different story, that pulcharimus is a major vector of malaria in Pakistan. So that's why I categorically mentioned the 1962 to 2017. It's a 55 years data of the country. And according to this country, and most of the data is published. So I just want to comparison of the Culissifacian, Stephenson, and Pulcharimus. And just this is the same slide. Because why I put this slide? Because in 2004, in 2019, sorry, or 1999, when I joined this program, malaria, not the national program, as a private sector, my supervisor asked me, you showed me this slide that there is no malaria in Punjab, why? And I have no answer because that was my early days of my early career. Why there is no malaria in Punjab? And by the neighboring province, Sindh, Balochistan, highly endemic for Punjab, for malaria. Then we start investigating why there is no malaria. Here it is. We published a paper 20 years ago. And if you look at this highlighted, our findings suggest that Anopheles stephensii has increased in the prevalence and become a more common than the Culissifaciae during the 90s, 80s, because the malaria become at the almost zero level in 80s. And we find some, because when my supervisor asked me why there is no malaria in Punjab, I could not answer. Then we decided to get the answer. And this is the paper when we will start working. And after 80s, the Culissifaciae was replaced by the stephensii. Why? This shift in the species dominance may be due to the large-scale ecological changes that have taken place in Punjab, where the irrigation induced waterlogging of the soil with the related salinity in Punjab, where the irrigation, and has created the environment that is favorable for the more salt-tolerant species stephensii. Actually, we found that after 80s, due to the rapid urbanization in the Punjab province and industrialization, the surface water becomes saline, and the Culissifaciae can't survive in the saline water. But stephensii has a wide range. That's why I call it a naughty species, because it can breed in a highly polluted water, it can breed in brackish water, it can breed in a clean water. But unfortunately, due to shortage of time, I cannot share another my study, which is a very big study, because we have spent almost 14 years investigation, particularly for this Anopheles stephensii in Pakistan. And we concluded that this species has a wide range of tolerance with the different physiochemical characteristic of the breeding site. So this is the paper which was published in 2004, 20 years ago. But yesterday I told you some different story that Culissifaciae was replaced, because here Culissifaciae replaced by stephensii, and stephensii is not an efficient vector in Pakistan. But after 20 years, Culissifaciae now is being replaced by the Pulcharimus, and Pulcharimus is highly efficient vector now in Pakistan, because after the introduction of the Pulcharimus, we have 20 times more malaria cases, and we jump from 300,000 to 3 million cases in Pakistan, and there was only one species, that is the Pulcharimus. Just to give you another taste of the mosquito-borne disease, the dengue. I just make the two comparisons. This I want to show what is the importance of the surveillance, why we are monitoring the vector species. If you look at the dengue appeared in Pakistan first time in 1994. From 1994 to 2003, for 10 years, there were only 700 confirmed cases in Pakistan, and there were only 6% population, and 4 districts were affected, and 6 deaths. During next 15 years, these 4 districts jumped to 145 districts. You can see the dengue appear every corner of the country next 15 years. And these 700 cases jumped to 300,000 confirmed cases of dengue in Pakistan. And 3,000 suspected cases jumped to 18 million cases, which indicate that dengue is the most rapidly spreading mosquito-borne arboviral infection in Pakistan, and it is very well evident from this. Actually, this is the slide of my previous presentation in European Mosquito Control Association last week in Spain, where I was talking about the impact of the climate change on the vector-borne diseases in Pakistan. So this was one of the slides was over there. And if you look at the mosquito, Aedes aegypti and albopictus, during these 10 years, we have only Aedes aegypti across the country, uniformly distributed in the country. This blue bar is showing the aegypti and pink part albopictus. There is no record of albopictus in the southern part of the country, but for next 15 years, you can see the albopictus highly acclimatized to the southern part, which is the hottest part of the country. Which now you can see that how these Aedes aegypti and albopictus particularly distribute across the country. And if you look at the indexes, which become almost double. Household index, container built index, so I will not spend more. This is just to give you a taste that what is the situation of the dengue vector in the Pakistan. And it is the most rapidly spreading disease in the Pakistan, and also very rapidly increase the dengue vector mosquitoes population in the country. Yes, this is very important slide strategically. You know that, maybe you know, that Pakistan has a very big trade with China. And China is covering the Central Afghanistan, Middle East through Pakistan. Pakistan is receiving hundreds of the containers per week, per day from the China, which are going to other parts as well. This is our second seaport in Pakistan. And for last 5-6 years, we are reporting the regular outbreak of dengue from this area where the dengue has never been reported. And if you look at this Chinese route, which we'll call CPEC, China-Pakistan Economic Corridor, we are receiving the hundreds of the containers weekly. And you know that the China is endemic for the Japanese encephalitis and some vector-borne. And Pakistan has a very high population of the Culex tritonurhanicus, which is the vector of the Japanese encephalitis. Japanese encephalitis is a highly endemic in China. And then we have the Kunki fasciitis, which is a case of the vector of the filariasis, and then Culex pipiens fatigans, and which is the vector of the West Nile virus. So all these three vectors have a very big population in the country. And if there is through this trade any infected mosquitoes through container or infected bird, the story of the dengue will be repeated in Pakistan, that how dengue spread in the world, that through the international trade. But that's why Pakistan has to be open eyes for these vector-borne, mosquito-borne diseases in the country, because we have a very big trade from China, and China is also covering the Afghanistan through Pakistan and also Middle East through Pakistan. Now I got to the step. Now there are some steps in the country how we can handle this situation. First, we develop our very sophisticated entomological laboratory in a university. I'm sure Dr. Michael McDonald knows that we have a very sophisticated National Institute of Malaria Research and Training Center in Lahore, which is actually a regional training center in Lahore. And Dr. Mike did his PhD from Pakistan, and he knows very well. But unfortunately, due to in 2011, we have changed in the governance system, and we make everything in the hand of provinces. So federal role was finished because that institute was in the hands of the federal government, but after 2011, it was handed to the provincial government. But unfortunately, due to certain reason, the provincial government could not run that institute, and that institute was closed. And we don't have any alternate institute. But for last 2 years, we established as an alternate, so the Pakistan established a National Entomological Reference Secretary with the collaboration with the Arad University, Rawalpindi, with the following key roles and responsibilities. Act as a center of excellence to fulfill the research and capacity building need of the country for sustainable management of the vector-borne diseases. Provision of the policy and strategic direction to the government and other stakeholders, monitoring the vector fauna of the country. This is one of the key functions of this National Entomological Reference Laboratory. And monitoring of susceptibility level resistant development trend of the local vector species, monitoring of efficacy of intervention. This is very important in aspect of our new laboratory. Because as yesterday I told you that we have distributed 20 million mosquito nets over the last 5 years, but malaria is still in the same direction, same trend. Why there is no impact of the 20 million mosquito nets? There were some reasons. One technical reason was that the mosquito biting time in Pakistan has been reported now early evening, and the people sleep in the mosquito net late night. So we have 6-hour gap between the sleeping time and the mosquito biting time, due to one of the reasons that there is still malaria cases are there, even in those areas where the 100% coverage was given to the target population. So these are the, and Center of Action, Center for the Public Health Pesticide Management. So these are our newly established laboratories system. And here we also act as a bank of the vectors. We also going to collect the reference collection from the neighboring countries, because pulcarimus, you know, that is a confirmed malaria vector in the Afghanistan and Iran. And it has never been reported. No, we are in, just like the Stephen size has gone to the Africa, and the people are investigating which is the origin of this African species, either it's Pakistan or India. Same case, we are also now investigating the pulcarimus. Is it from the Afghanistan or from Iran? So that's why this is one of the reasons that we are establishing this, our laboratories. To ensure the sustainability of National Malaria Control Program, University, there is a memorandum of understanding. Very interesting that within 2 years, we have completed their, we have 2 PhD students, 3 PhD students, and 3 master and bachelor students who are doing that, they're conducting their research in these laboratories. So which means that the laboratory is fully functional, and the students are now doing their PhDs, master in using these facilities. That's very important, another aspect. Why I'm sure. We are going to introduce in the country the drone technology for the control of some mosquito-borne diseases like dengue. Why? Look at this picture. You can see the mountains of the plastic bottles, empty bottles, containers, and I'm here to see what is the positivity rate. Can you imagine that 67% bottles were positive with Aedes mosquitoes? Can you believe 67%? Because 31,000 mineral water bottles produced per month in a 1 5-star hotel in Islamabad. Where those bottles goes? 31,000 mineral water empty bottles. Because then there is a new business. Poor people collect those bottles and they use it and they keep it for before the. So look at this. And people hide this business because this is an illegal business. And this is one of the identified reasons of dengue outbreak, regular outbreak, particularly in capital Islamabad. And can you imagine that you can go there upstairs on the top of these heaps of the plastic container for the treatment of these containers? Not possible. Not possible. So that's why we decided to have some drone technology, because the people was not allowing us to go there to see these things. And now you can see, using the drone, we are making the mapping of these heaps of the plastic. These are plastic bottles. So it is not very good picture, but you can see these are plastic bottles. Inside the houses, these are small, you can business inside the houses, where the people keep container, empty bottle for over the months and months, but they are creating the problem for the dengue. In that, after that, we are also using this that laboratory for development of some local products, like these are repellents, nano encapsulation of the grapefruit oil, and these are the product of the student. Within 2 years, the laboratory has is capacity that the students have started these sort of things, and for their PhD research, nano encapsulation grapefruit oils, nano encapsulation the citrus oil, and we are developing locally. These are the students' product in that laboratory. This shows that now the country is reviving its status of the early 90s, when we have the state-of-the-art surveillance system for the mosquito in Pakistan. But unfortunately, due to certain reason, after 90s, we have a gap of 20 years. Then when the country has next step. You know that this surveillance, if you have a very concrete evidence or very concrete data, you can develop an evidence-based strategy, national policy. If you don't have the concrete evidence, you can't have your evidence-based strategy for control of the vector-borne diseases. to ensure the sustainability, now the provincial government also encouraged to establish these provincial laboratories at the provincial headquarters and up to district level. And then one of the Punjab province, which is almost malaria-free, I'm telling you, they have already established their provincial laboratory at the Institute of Public Health in Lahore, which is just next door of the IPH, of NMRT. Then establishment of the experimental hut. This is our next target. We are going to establish experimental hut to strengthen our capacities for the evaluation of the products in Pakistan. Then establishment, accreditation of these laboratories and the partners, particularly the Vigro Apps Denmark. I'm very thankful to Rone for wonderful support for this laboratory, and then UNICEF is now jumping. WHO, GFR have shown their commitment for the future strengthening of this system in Pakistan. Thank you very much.
So thank you so much, Dr. Mohamed Mukhtar, for very impressive presentation with the drone technology. Thank you so much. Now we move to the next presentation, Myanmar status of malaria and its new strategy for malaria control and innovative stratification. Welcome, Dr. Ung Myo, Assistant Director from NMCP Myanmar. Over to you.
Good morning, Chairman and all participants attending this annual conference from various countries. First of all, I would like to introduce myself. I'm Dr. Aung Myo, Assistant Director from NMCP, Department of Public Health, Ministry of Health, Myanmar. I would like to present malaria status of Myanmar and its new strategy for malaria control and innovative stratification. This is my presentation outline. This is a border area of Myanmar, India, China, Thailand, and Laos. This is a malaria situation in Myanmar. The data show 2012 to 2022. This is the annual blood examination rate, test positivity rate, and annual parasite incidence in 2012 to 2022. This slide shows that Plasmodium falciparum mix and Plasmodium virus ratio in 2012 to 2022. Throughout the data, it shows that Plasmodium falciparum case red line declined significantly, but Plasmodium virus cases increased gradually later year. This is a vector control strategy in Myanmar. Current vector control measures in Myanmar are IRS, LLIN, environmental management, use of personal protective measures such as repellents and clothing, and HE. Challenges we have faced in implementing vector control in Myanmar are limited access to remote and conflict-affected areas. There's more conflict-affected areas increasing during these 2 years. There is resistance of mosquito to conventional insecticides, seasonal and geographical variation affecting control efforts. There is environmental changes like heavy rain and flood during this year. Lack of community engagement. This is the innovation in vector control technique in Myanmar, application of spatial repellence, GIS, community-based participatory approach, research. There is impact of vector control on malaria transmission in Myanmar, reduction of malaria transmission, improvement of health outcomes, enhanced community resilience, and strengthening of overall public health system. I'd like to talk about the next topic, surveillance and case management. This is an overview of current surveillance methods in Myanmar. Passive case detection, active case detection, drug-resistant monitoring, and collaboration with local communities for early detection and reporting. And we are facing some challenges during this year. This is limited access to healthcare facility in remote region, under-reporting and misdiagnosis, insufficient trained personnel during this year, and surveillance gap in border region and conflict zone. Conflict zones are increasing this year. This is the integration of technology for improved surveillance, use of mobile health, mHealth, and GIS, and integration of data analytics for predictive modeling and risk assessment. For improving case management and treatment access in Myanmar by training healthcare workers in accurate diagnosis and treatment, implementation of telemedicine and mobile clinic in remote area. There's key achievement are reduction in malaria cases and scaling up airline distribution and IIS campaign in high-risk area, and collaboration with international organizations and NGOs, and improve community health outcomes. This is the challenges in malaria control in Myanmar are, this is a very challenging, complex political and administrative landscape affecting program implementation, and difficulty in reaching remote and hard to access region for surveillance and intervention, and this is security concern and logistical constraint. This is a way forward of malaria control in Myanmar. This is integration of malaria control in broader health, investment of capacity building, it is very important, and upgrading and equipping healthcare facilities, and promoting community participation in surveillance and vector control activities. This is a development of intensification plan and acceleration strategy in Myanmar. It is a standard operation procedure activity for intensification plan and acceleration strategy. Submission of pilot project to 21st June 2023. I'd like to talk about the next topic, stratification. In Myanmar, stratification is based on recidivity, vulnerability, and disease burden. Disease burden is manageable or not. It is in Straton, it is different from Straton E. If the village is non-receptive, it is Straton E. If the area is receptive and CIFA, case investigation, foresight investigation and response, was conducted to all cases, it is stratified as Straton B. But no indigenous case for 1 to 3 consecutive calendar year, it is stratified as Straton C. And no indigenous case for more than 3 consecutive years as Straton D. This is a strategy A, strategy for Fasibrand and strategy for virus. It is different. In strategy A, there is no manageable case. In strategy B, there is manageable case load, so all positive cases need to be notified and investigated in this strategy. It is a strategy C. In strategy C, surveillance must be strengthened and appropriate response for every positive cases. In strategy D, there is continuous monitoring and quick and prompt response of importation of parasite is very important. In strategy E, there is non-receptive area, early diagnosis and prompt treatment of suspected malaria case, and positive blood donor, positive blood recipient should be investigated to know the place of source of infection. This is an intensification plan and acceleration strategy by Stratem. A, B, C, D, E. It is a pilot project on IPS strategy. Submission of pilot project due to 21st June 2023 with 4 states and regions, Bago, Muar, Ayeyarwady, and Tien Tay. It is my last presentation, and thank you very much for your kind attention.
Thank you so much, Dr. Ung Thi, for a very clear picture of malaria situation and control activity in Myanmar. Thank you. So we move to next presentation from Dr. Ibban Eliazar with the current status of malaria in Indonesia. So please, over to you.
Thank you. Good morning, everyone. Thank you, Chair. Thank you, APMEN, for inviting us. I'm here with Ms. Nurul Muafila. She is one of young generation or our national malaria control program. So we're happy to be here. I'm from the Indonesia. It's one of the research partner that supported national malaria control program for years. So we would like to present about the current status of malaria in Indonesia, the challenges and opportunity as well. This one? This one? Okay. You can see that Indonesia is working very hard to reduce the cases over the years. In the last, I think the last 10 years, we see that malaria cases up and down, evaluated. The last 2 years, Indonesia is intensifying the case of detection, especially the active case detection. And you can see that there's a significant increase of the malaria trend in Indonesia in 2022. But this is the national pictures of the malaria in the country. But if we shortlisted the country based on the province, we see that over 90% of the cases reported from these 2 provinces, Papua and West Papua. These 2 provinces are located in the Papua Islands. Yeah, you can see that this is a significant progression of malaria in Papua in terms of the composition of the contribution of malaria in Papua and outside of Papua. You can see that you can see that in the beginning of 2010, most of the cases come from the outside of Papua, and due to the extensive malaria control program at outside Papua, the malaria is diminishing at the outside, but still the problem in the Papua region. But if we look at the higher spatial resolution, especially at the district level, we see that Indonesia is trying hard to achieve the regional sub-elimination, at the subnational level, actually. You can see that at this year, Indonesia has provided a malaria-free certification to about 75% of the district across the country. It's about, I think, 390 of the 415 districts in Indonesia. Let's see, for examples, in Java and Bali, where these islands, where most of the population of Indonesia live in the island, 60% of the population live in this island, we almost clear the malaria in this area only in one district here in Purworejo. Last year, we observed the outbreak because a massive returning forest worker from this one and this island. So we observed there's about 200 cases outbreak of malaria last year. And let's see for about this one, Sumatra, Sulawesi, and West Nusa Tenggara here, 84% of the district has received the malaria-free certification. And Kalimantan here, and then North Maluku is about 68%. Maluku here, and East Nusa Tenggara, 36%. And you see here, it's only one district of the 42 districts had declared as free from malaria. But it's still a problem. If you are declared malaria-free, but your neighborhood is on fire, so it's very difficult, it's struggling to maintain your elimination certificate. And you can see that here, the number here is the year of the target, the roadmap of the malaria elimination at the regional level. Indonesia is expecting to clear the malaria in this island, Java and Bali, 2023, 2025 in this one, and Kalimantan, 2027, 2028, and 2029 in the Papua. So let's see this one. What is specific interventions? So Indonesia put some strategic based on the criteria that I saw you before, based on the risk stratification. For example, in the high endemicity, API above 5 per mil, the objective is reduce the cases as quickly as possible. Indonesia call it as acceleration. The main interventions still rely on the mass and distribution I think every 3 years. And then also doing IRS, but only to village with the high API above 20 per mil. And then malaria screening to all pregnant women, routine LRN distribution, and also malaria screening to all sick children. This is the strategy for those high endemic district. What about the district with the moderate endemicity? The objective is to eliminate the focus area, because the problem is not the whole area, but only in the hotspot. Still, the key intervention is distribution to the high-risk population or to the population who live in the focus areas, as well as intensify the active case finding, and also the IRS. What about the low endemic with the IPL less than 1 per mil? Indonesia is emphasizing the intervention to the migration surveillance. You will see that the high connectivity among the island, also among the district. And you can see that you also intensify the epidemiological investigation. We choose 1 to 5 strategy to the all positive cases detected at the low endemic areas, and also mapping the receptive area. The problem with Java, Bali, Sumatra, Sulawesi, and others, even though malaria are free there, malaria local free there, but the area is receptive for malaria. So we are still struggling to maintain about this one. In terms for the elimination district, the strategy, as you can see here, still rely on the migration surveillance, epidemiological investigation, mapping receptive area, and also ascertaining the vector surveillance. Okay. And Indonesia now is trying to testing several strategies. The first one is how to accelerate reduction in Papua. You can see that Indonesia is focused on 9 districts with the API above 100 in Papua. And the activities here is increase the active case finding and incorporate also the school teacher as a part of community-based engagement, and also trying to integrate the vector management here, and then larva source management. The second strategy is to pilot the malaria mass drug administration at the 4 villages at the 2 districts. With these 2 districts, Kerom and Jayapura, they reported over 400 cases per meal for the last year. And the idea is to giving the hydroxychloroquine, piperacin, and also primaquine for 3 days, and then also implemented the 3-round monthly up to 3 months. And this is a part of the strategy to accelerate reduction of malaria. Yeah, you know that some controversy of MDA, because WHO recommended if you would like to implement MDA, you can do that in the low endemicity, but not in the high endemicity. But we are trying the best to pilot, to try whatever we can do to reduce the malaria in Papua. The other one is forest intervention package. The problem with Indonesia is mobile and migrant population. We are dealing with the last challenges of the forest worker and dealing with the activities there, and then we try to pilot also in East Kalimantan, in several districts here, by providing intervention package to the individual, to the forest goers there, by giving the LRN, repellent, and also we're doing the bi-weekly visit to their, working site, also to their working camp. But we're also doing the village fever screening, the area surrounding the forest. And the last one is giving the malaria prevention medication for individual who will report to go to the inside the forest. We're giving the medication for 1 day. Yeah. What the issue of challenging achieving malaria elimination in Indonesia? The first one is about very receptive to malaria transmission. So actually there is one success story in the Halmahera in North Maluku. You can see here, this is the situation, the condition here is a very fertile for anopheles breeding site. And then due to the community engagement, they're doing by themselves to clear off the breeding site. And you can see that there's a lot of significant reductions of the malaria cases in these areas. So Indonesia is thinking to implement the home improvement, environmental improvement as well, and also the need of medical entomology. We discussed a lot of yesterday. Indonesia think about having like a regional medical entomologist to support that provincial and also district level. The last one is a village funding support. What is the second issue? In Papua, as you can see here, the mosquito is early biters, tend to be anthropophilic, and the comparable composition between the indoor and outdoor. So the main problem. And Indonesia is mapping about the needs. They want to do the source reduction as well, optimizing both intervention, LRN and LSM, personal protection, and providing the support for those high endemic districts. This is the heterogeneity, it's the vector diversity of Indonesia. We are talking a country where they range from the London to Kabul. So from here, in the west to east, and you see the variety of the vector there. So in the last our systematic review, we confirmed at least 24 confirmed malaria vectors species in the country. You can see that every part, every regional, we have a challenge here. And yeah, you know that they have a different characteristics of the behavior as well. There's the third challenge about preventive action by the community, because when you live in the area that commonly attacked by the mosquito or the malaria, you lost your sensitivity. You lost about the fear of the disease itself. So they thought that the community feel that this is common to have malaria. And some joke mentioned that when you visited Papua, if you not get bitten by malaria, so there is no proof that you are there. So this is time of joke. And then you see that people don't take malaria medicine completely, especially for Prima Queen. You need to take 14 days for the ViVac. There's no one complete the full medication for ViVac. And we see also the high problem of relapse malaria in Indonesia. 70% of the soldiers returning from the Papua to Java to the Sumatra experience relapse because they didn't complete the ViVac anti-relapse in Papua. The fourth problem is about mobility. You can see that high mobility across the island here. And the problem also with what do you call it, the mobility of the forest worker across the island. This is 1 hour study to explore the secondary malaria data at the National Malaria Control Program. When we talk about the contribution of mobile migrant population to the total case of malaria, you can see this is the province level. Let's see here. For Aceh in Sumatra, 80% of the cases come from the mobile immigrant population, from the forest goer. You can see also in the Sulawesi, you can also see in South Kalimantan, it's over 70% of the cases. So this is one of the challenges, that's a serious challenge by elimination in the country. And the last one is about implementing reporting for the surveillance activities, as you are now well aware of it. And Indonesia is trying to testing about the mass drug administration. The idea is to do the 3 month, 1 month, 1, 2, 1, 3, and then we try to evaluate the impact compared to the previous 12 months and to see that also the post-MDA, we tested in area here, in Jayapura and Kerom. This is the picture of the supervised administration by the village worker. And yeah, the study is still going on, the pilot program is still going on. The coverage is about 80%, but we also see the rejection is about 5 to 10% in Jayapura. And also they reported about 1 to 5% of the side effect complained by the resident, village resident. And this is one of testimony actually. This is Dr. Hanover is the head of the Puskesmas Primary Health Center in Jayapura. Before the MDA, he saw that it's about 100 cases per month, but the last month he only saw about 2 cases. Yeah, we don't know. We understand about the consequence of MDA during the MDA, but we see the bounce back. But yeah, we need to think about what additional intervention to support this one. The last one, thanks from and greeting from the All National Malaria Control Program. Thank you.
Thank you very much, Dr. Iban, for very detailed presentation, and also congratulations in Indonesia apply the new strategy for malaria elimination, that is the MDA. Thank you so much. Now we go for the next presentation is effectiveness of dual active ingredient insecticide Gitternet with Dr. Dr. Timothy Baker. This is an online presentation. Welcome, Dr. Timothy.
There you go. Is everyone able to see my screen?
Yeah.
Yeah, looks good.
Good work, well.
Tim, thank you very much. And your slides are showing up very well. Thank you, Tim.
Yeah.
All right, excellent. Thank you for inviting me. My name is Dr. Tim Barker. I am a research fellow as part of HESRI, which is Health Evidence Synthesis Recommendations and Impact for the University of Adelaide. I am the Deputy Director of the JBR Adelaide Grade Centre, and I'm a research methodologist and systematic reviewer. Before I get into my presentation, I just want to acknowledge that I'm joining this meeting from the traditional lands of the Kaurna people from Australia. In Australia, it's very important that we acknowledge the traditional custodians of the land, and the University of Adelaide is founded on the lands of the Kaurna people. And I just want to acknowledge and pay respect to their contributions and their connections to the land. Here are my disclosures and my potential or actual conflicts. I don't believe I have any potential or actual conflicts. I do receive research funding. The research funding that I receive goes to my immediate research group. I do not receive any funding personally. Importantly, I have never received funding from pharmaceutical companies or industry partners. Neither has my wife, who works in a very similar area that I do. In this presentation, I'm going to be talking about some of the results of a recent systematic review that I did as the JBR Adelaide Grade Centre in collaboration with the Vector Control and Insecticide Resistance Unit in the Global Malaria Programme of the World Health Organization. This review is only very recently published. It was published in August of this year. You can see the paper on the right, and if you wanted to follow along, you can scan the QR code, which should take you to the paper, or you can take a photo of the screen and find it that way. But everything I'm going to be talking about comes from this review. I'm going to be, for sake of time, glossing over a lot of the salient information and the important facts, but obviously all the details in the paper. So just very, very quick background. Currently, the WHO recommends that insecticide-treated nets that are treated with a pyrethroid-based insecticide should be used for large-scale deployment in malaria endemic regions. However, recent findings have shown that the most common malaria vectors, being Anopheles gambiae and Anopheles funestus, have started to develop resistance to the pyrethroid-based insecticides. In order to potentially combat this resistance, the WHO have started to investigate dual active ingredient nets. So insecticide-treated nets that have more than one active ingredient impregnated into the nets to try to kill or facilitate assistance of killing the mosquitoes when they come in contact with the net. So that was a bit of very quick background, and with this understanding, we engaged in conducting a systematic review to assess whether new, I'll call them dual active ingredient insecticide treated nets, or DAI ITNs, whether these new DAI ITNs would actually prove to be epidemiological beneficial to the population that they're being assigned to. Now, I'm going to be presenting the results of this work, but I'm going to do so in terms of the comparisons that we investigated. And so I hope this makes sense. We explored 4 different pairwise comparisons as part of our systematic review. The first were DAI ITNs that were treated with clofeniper and pyrethroids, and these nets, these DAI ITNs, were compared to pyrethroid-only nets, or standard nets that are typically recommended by WHO. Our second comparison were DAI ITNs that were treated with clofeniper and pyrethroid, and these were compared to pyrethroid PBO nets. The third comparison were DAI ITNs, but these were treated with pyriproxyfen and pyrethroid, and these were compared to pyrethroid-only nets. And the final comparison that we investigated were DAI ITNs treated with pyriproxyfen and pyrethroid, and these were compared to pyrethroid PBO nets. So I know that was a lot of verbose information, but it is important in terms of how I've actually presented these results. So on to, I guess, the results of that systematic review. Oh, sorry, the inclusion criteria is what we're looking at. We limited studies to only those that were cluster randomized controlled trials or non-randomized but at least controlled trials. And the clusters needed to include more than one unit. So if it was a cluster of villages, it needed to include more than one village per cluster or one hospital or so on. We're looking at adults and children in malaria endemic regions. Importantly, we did not look at nomadic communities, travelers, or migrant workers to malaria endemic areas. They had to be residents of these malaria endemic regions. I've gone over the interventions. And the outcomes we're looking at, we only were interested in epidemiological outcomes. So epidemiological outcomes, also known as patient-important outcomes, are outcomes that are important for the patient. We weren't interested in entomological outcomes or efficacy-based outcomes, so do these actually work? Only outcomes in terms of what are patient important. We did include some data about contextual factors, particularly costs, acceptability and feasibility of how these interventions should be or could be implemented in their setting. Onto our results. So this is a PRISMA flow diagram. For those of you that are familiar with systematic reviews, PRISMA is the gold standard reporting standard, and as part of following PRISMA reporting guidelines, you should construct a PRISMA flow diagram that details how studies move throughout your systematic review. So in short, what this shows us is that we conducted a peer-reviewed comprehensive search over multiple different databases, so 4 databases and 3 clinical trial registers, and we identified 9,494 different records that we needed to screen, and we screened based on relevance to our inclusion and exclusion criteria. I won't bore you with the details of that, but at the end of our screening process, we identified that there were 3 studies that met our inclusion criteria. However, these studies were reported in 13 different reports. So it was one study that had been reported multiple times. One study was identified through direct contact with the authors. So we identified the trial register that they were doing the trial. We got in contact with them and we got their data from them through direct correspondence. So we ended up with 3 studies included in our systematic review, and these are the results of our included studies. These are the actual studies themselves, I should say. So again, I've got a few QR codes if you want to scan them or take a photo so you can check the included studies themselves. But they were in order of publication: Chiono et al. 2018, Moshe et al. 2022, and Akron-Bessie et al. 2023. These were the studies that we included in our synthesis and our systematic review. So I'm going to present now the main results, or at least the main findings of our systematic review. It's important to note that we did do formal meta-analysis. We did do formal synthesis of our results. We did risk of bias assessment and a grade certainty of evidence assessment as well. However, I haven't included any of that in this presentation, purely for sake of time. I presented my results as neutrally as possible using what we call grade plain language statements. These grade plain language statements, they're very formulaic. They're meant to inform decision makers in making a recommendation for practice. So they are very formulaic, and I've done so mainly because I am not a malaria-based researcher. I'm a research methodologist and systematic reviewer, so I don't particularly know what a large or small effect is. All I can tell you is what the effect was as a relative or absolute unit. So I just want you to keep that in mind as I run through these results. And I'm going to do so based on the comparisons that I introduced to you earlier. So the first comparison were clofenipa pyrethroid ITNs versus pyrethroid-only ITNs. And our main findings were that the people or the clusters that received the intervention, the DAI-ITN, they did experience a reduction in malaria case incidence and parasite prevalence at 1 and 2 years post-follow-up, and at 6, 12, 18, and 24 months post-follow-up for parasite prevalence. And those that receive the intervention will likely result in a reduction of malaria case incidence overall. And the overall assessment is just these 1 and 2 years post follow-up combined into the one data point. So it's showing that this intervention will result in a reduction of malaria. Our second comparison were clofenipa pyrethroid ITNs versus pyrethroid PBO ITNs. Again, the clusters that received the clofenipa pyrethroid ITNs, they will result in a reduction of malaria case incidence overall and at 2 years post follow-up, will result in a reduction of parasite prevalence 24 months follow-up. They will likely result in a reduction of parasite prevalence at 12 and 18 months follow-up, and there is little or no effect at 1 year post follow-up. Moving on to our third comparison. So now we're no longer looking at clofenipa pyrethroid ITNs, but pyriproxyfen pyrethroid ITNs. What we can see here is that clusters that receive the pyriproxyfen ITNs, they will result in a reduction of malaria case incidence overall 1 and 2 years post follow-up, and parasite prevalence at 12 and 24 months follow-up, and those that receive, and they will likely result in a reduction of parasite prevalence 6 and 18 months follow-up. Finally, I know this is a lot, sorry. Finally, the last comparison were pyriproxyfen pyrethroid ITNs versus pyrethroid PBO ITNs. Now, this is important because this was the only comparison where the intervention actually was more harmful. So what we see is that the people or the clusters that received the pyriproxyfen pyrethroid ITNs in this comparison actually had an increase in malaria case incidence and parasite prevalence at overall and 2 years post follow-up and at 18 months post follow-up. Clusters that received the pyriproxyfen pyrethroid ITNs, they will likely result in an increase of malaria case incidence at 1 year and at parasite prevalence at 12 months follow-up, and there will likely be a reduction only at parasite prevalence at 24 months post follow-up. So again, I know that was a lot of very formulaic results there. A few limitations and research gaps. We have assessed the certainty of the evidence. Most of the evidence is high certainty following the GRADE approach. We did have to downgrade a few of our outcomes due to concerns with imprecision and inconsistency. So that means we have moderate or low certainty of the evidence. We weren't able to assess publication bias systematically because we didn't have enough data points to construct formal funnel plots. But we did do a very comprehensive search that was peer-reviewed and constructed with a medical librarian. We only restricted based on study methodology, so we should have then covered all of the international literature available. One thing, all of the studies were conducted in African countries and in high transmission settings, so where malaria is, the transmission rate of malaria is very high. So the baseline risk of our data was extremely high. Future trials should be looking at longer than 2 years post-implementation, because that was our longest point of follow-up, and at different transmission settings. So to finish, what does this mean for practice? The WHO, based on this research, have made 4 new recommendations for how insecticide-treated nets should be deployed in malaria endemic regions, particularly where the mosquitoes or the vectors in that region have demonstrated insecticide resistance. Now, once more, this evidence comes from, these recommendations have come from the WHO. You can see the webpage where they've made these recommendations on the right, or you can scan this QR code again if you want to be taken to where these recommendations actually are. Very quickly, the most important one was that the WHO are now strongly recommending that the pyrethroid clofenipa DAI ITNs should be deployed over the pyrethroid only ITNs in areas where malaria resistance has been documented. So thank you very much for allowing me to come today. Thank you for allowing me to present over Zoom. I really appreciate your time.
Thank you very much, Dr. Tim. Tell us about your study on the effectiveness of insecticide-treated net. So thank you for one presenter. So now I know many participants eager to have some question for interesting presentation.
Doctor,
Yes.
I just want to make an announcement because we are running out of time. So
Oh.
we can shift this question answer before the lunch. So we will continue the presentations, and after the two presentations, we will have a common question answer. So this is just suggestion. If you agree that, yeah.
Great, Muta. Thank
Yeah.
you. Okay.
So sorry for this inconvenience that we are running out of time. So that's why we decided to have the question answer before lunch after all this presentation.
Okay. Thank you.
Thank you very much.
Thank you. Okay, so yeah, we go to the next presentation from Dr. N. Haji Amadou Niang with presentation on vector control platform, how they work. Pamka, over to you, please.
Thank you, Chairman, and good morning, everyone. I first want to thank really the organizer, Leo, and team really for having me here and giving us the opportunity really to share what we do in PAMCA, but also really appreciate attending this because I've learned a lot since yesterday, and we hope really that this is going to be a long-term collaboration, and also expecting to have AMCA people for our next conference, which is in September in Côte d'Ivoire at Abidjan. So I'll just try quickly to take you through what is PAMCA. Just to let you know that I am the interim director of the scientific program, and an interim term that is taking longer than I was expecting because I agreed to join for a very short time because I had other commitment, lecturing at the university, being involved in RBM and WHO. But since I joined, I really found that there was a lot to do, so that's the reason why I'm still interim. And also I am lecturer at Sheikh Anta Diop University, our medical entomologist professor. So what is PAMCA? PAMCA is an African collaborative network. It brings key stakeholders that are scientists working on vector control and VBDs, but most importantly, NMCPs, policymakers, communities, and we provide a kind of a collaborative network that actually allows those people to really work together to eliminate vector-borne diseases. And our vision is an African-free of vector-borne disease. And the reason for us to be really here and really supporting all this work is rooted in a united narrative to fight against vector-borne diseases. So what is our mandate? So based on what I've said, so it's just to create a safe space for all these stakeholders, medical entomologists or public health entomologists, professional, and this is really to create this environment where they can collaborate, drive synergy in vector control and elimination of VBDs, disseminate knowledge. I think that's super actually what we are doing here, learning from each other, seeing what are the situations in each of the countries that are presenting here, and see what we can replicate elsewhere. Those are also the reason why PAMCA is existing. And also to promote new intervention. You see we have some programs that are focusing on Gen Drive and some other program focusing on genomic surveillance. All these in order to really strive and be able to really accomplish our goal, which is to eliminate VBDs. And of course, we do this in IVM approaches, which actually integrate all the tools that we have, but use them in a rational way that actually can make it much more impactful. So the way we are constituted is we are an African registered member-based association operating as an NGO. And our day-to-day operation as an association is lead at the secretariat, so which I'm part of. So we have an executive director, which is supported by a secretariat, which we have the headquarter in Nairobi, in Kenya. So, and we are 4 now at the secretariat, something like 25 staff. But after that secretariat, you're going to see that we have a regional center of excellence. I'm going to elaborate in some side. But also we have country members, chapters, where we implement whatever we do as PAMCA, so as you can see here. So to become a member of PAMCA, it's open to anyone working or having an interest on VBD's vector control and also supporting all the VBD's work in Africa. And we have different membership category. We have individual membership. We have educational and research institution membership. We have corporate membership. We have government membership to make sure that we allow all these key stakeholders to really join the organization and contribute to their way and benefit also to their way from the organization. And the membership runs from January to December. So the way really we operate, our operating model is, as you can see, I've said, so the oversee and the program is really sit at the secretariat, where we have our global program portfolio. But we made sure also that we have different virtual community of practice with some thematic focused collaborative group. We have country chapters, which are really the implementers of our programs. I'll give some example later on. We have regional center of excellence because we find out that having country working in silo is not effective. And most often they have the same issue. And as I used to say, we need visa to travel, but mosquitoes don't. So it's most often a regional problem, which when people join effort, they can much more effectively come up with solutions. And these are the different initiatives we are creating in PAMCA to make sure that we create a safe space for key stakeholders, NMCPs, to really discuss in the region what they do. And we have a regional steering committee with regional experts, NMCPs, PAMCA country chapters, and we have a global scientific advisory council. And all this is actually overseen and guided with a PAMCA global board. And we recently renewed our global board with very new and strong scientists that are really supporting developing the vision strategy of PAMCA. We work with regional agencies, WHO, AFRO, Africa CDC, other NEPAD, and other African health organizations. We have several donors which we work with, and our main donor is Bill and Melinda Gates. Sorry. And we have country technical working group where the NMCP is supported by PAMCA country members to really support all the surveillance system and the decision-making process and making sure that we support strengthening the system for evidence-based decision-making in those countries. So this is more or less the different countries that we are actually operating in PAMCA. So as you can see, 11 of them are fully registered. I think I made that mistake here, and 11 are actually in the process of finalizing their registration. And we have different programs that are actually run in different countries based on the need that was actually seen in those countries. And as I said, we have a regional center of excellence in Tanzania, in Cameroon, in Burkina Faso, and in Ethiopia. And there is a reason why we've selected this. I'll elaborate later on. And as you can see, these actually are leaders, research institutions in the region. And the reason why we selected them, they have a lot of capacity They've proven their leadership, and most of the PIs that actually are leading this institution are renowned researcher. In Ethiopia, we have Professor Delenoso, and the reason why we have selected this region, or in this region, Ethiopia, is because of Anafele Stephen Zai, with the experience that I have. And the reason why also I'm here and learning from colleagues here is you have huge experience on Stephen Zai, which we need also to benefit from and try also to support the country that we are working with in the continent to make sure that we have the right capacity to address this invasive species. In Cameroon, we have Professor Charwenji, who is one of the leader in the insecticide resistance aspect, specifically for the metabolic resistance, which is one of the area where we need really to make a lot of progress. And in Burkina Faso, we have Professor Abdoulaye Diabate, who has a lot of experience on Gen Drive, a part of the Target Malaria Consortium, and really leading the work in that. And as I said, in Tanzania, we have also IHI, where we have a lot of ecological study, a lot of competencies, and they actually supported the development of our curriculum for the district entomology training. And as I said, so we work with different key partners, technical partners, as I said. We have some financial partner, but also network partner. And I think in this list, I'll be adding APMEN to make sure that we maintain this collaboration. And the idea is also me coming here to think and reflect about the potential way we can formalize this relationship, potentially through an MOU, or we can discuss it later whenever possible. So some of the projects that we have, actually, as I said, so we have 8 projects running right now, which are funded by different funders. The main of our funders is Bill and Melinda Gates, who is funding our 3 program, I would say our flagship program. So we have this entomological surveillance project, which aim at actually strengthening local capacity for malaria surveillance and elimination. And it's a 5-year program, which has been implemented in 3 of our regional center of excellence in the pilot phase, and now we've actually scaled up to 4 more countries, which actually added up as 7 countries, where we start by doing a situation analysis survey, where we try to see what are the capacity in the country in terms of human resources, in terms of gender balance, in terms of infrastructural research capacity and everything. And then once the gaps are identified, we work with the NMCP to prioritize what are the activities that we need to put together. Some of them actually request from us to do some kind of district entomology training, and I'll show some example that we have here. We have also the vector genomic project. We find out that the vector genomics, the vector genomic surveillance is something now that we can't avoid, because some of the limitation that we have with our traditional method of surveillance need really to be fixed. And the genomics is coming in, but we got to realize that in the continent, we do not have the capacity in terms of infrastructural capacity. But once you have the data, once you have collected your mosquitoes and got them sequenced, we need bioinformatic capacity to be able to analyze those data and summarize them in the way that we can share it with the NMCP to make decisions. And so we had actually got funding from Bill and Melinda Gates and worked with Sanger to actually sequence sample from several countries, but also be able to train young African on bioinformatics. And we have also the Women in Vector Control program, which is one of our, I would say, best program, which actually came from the finding of this surveillance system. We found that, so, and I think it's something that most of us know, that in the continent, the vector or the entomologist profile is a man-dominated area where most of the women that actually get in at some point got dropped off. And so we wanted really to also sort out, and we were actually also supported by Bill and Gary Nugget. And we have the African Gen Drive for network, which aim at improving the collaboration and building knowledge at the NMCP's level, because it's a tool coming in, and we want the NMCP to have the capacity to make an evidence-based or decision-making wherever they would. And we try really to increase the awareness about the tool and also let people know what are the key added value of the tool. And we, of course, the NTDs, we had some fine funding on developing and enhancing data through some capacity building in data analysis. And also with PMI, we've been involved in some durability monitoring. And also for data management, we have developed a tool which is known as Mosquito DB, which we support the NMCP actually to be able to collect the data using a mobile phone and have a platform where they would have the dashboard and just have all the data displayed and in a very meaningful way so that they can use those during the technical working group and be able really to make decisions. So this is really how I would say our house is built. This is our vision on Africa free of vector-borne diseases. And the mission is really to provide a collaborative network where all the key stakeholders would be able to be working together, co-create, share, listen, and support each other to be able really to manage vector-borne diseases. And our enablers are people. The staff or the people are really our greatest assets, and that's the reason why most of our activities are around capacity building, but also operational excellence. This is why we have our regional center of excellence, where we train people, support countries to come up with very operational resources. Resource mobilization, integration, and communication outreach. And the house is actually built on 4 pillars. The main one is entomological surveillance, because you can't do any vector control intervention without really having a strong entomological system to be able to really target your intervention and have the cost-effective one. And it's also allowed to actually monitor your intervention and see the impact that you're having. So, and this included standard surveillance and data management, genomic as excited resistance surveillance. Intervention testing and deployment, such as the durability testing. We try also to build those capacity in some of our regional center of excellence and some of our region to be able to really monitor the tools and make sure that the tools that are actually deployed in those countries are effective and protecting population effectively. We also think about the innovation and translation, such as some of those tools around the Gen Drive, but also looking at all the other new innovations that are upcoming and being able to really support the country to be ready for those new tools and be able to make the decision of using them. And of course, emerging and re-emerging risks such as invasive species. Defensa is one thing that we are really looking at. And Dr. he knows that we've organized a specific panel for Stephensi during our last conference. So we have cross-cutting thematic area that is the basis. So this includes research, capacity building, advocacy, and policy. That's the reason why we're working with ODA, NEPAD, and all those high-level organization, Africa CDC, multi-sectoral collaboration, diversity, equity. Women in Vector Control program is here, and we want it to be cross-cutting in all our program, and also making sure that when we implement, we monitor and be able to really improve whatever we do. And of course, to make sure that we have the highest standard of what we do, we make sure that we've built some Center of Excellence. For now, we have 4, one in the Eastern Africa, in Ifakara, one in the Central Africa, at Crete in Cameroon, one in the Western Africa in RSS, and now we have one on the Horn on Africa. And our aim is actually to develop another one in the Northern Africa and the Southern Africa. The Southern Africa one, we've already started discussing and having some country, because we work with the EA initiative, and they will decide where we will be setting up this Center of Excellence. And we still really need to work on the Northern Africa, where we would see that we still really have to do a lot in that side. So the chapters that we have and some of the goals that we have in really strengthening what we are doing in the Horizon on 2030 is really to set up these regional center of excellence and finalize the registration of the country that are actually working. And this is actually creating a real virtual community of practice where lessons learned are shared. And so I just want to show some example of achievement of our different programs. So as you can see here, as I said, we started this program in our regional center of excellence as pilot study, where we tried really to do a situation analysis, see what are the gaps, and implement our surveillance program. And once we've learned from that phase 1, we actually scaled it up to phase 2 country, and we expect it also to include more country. So in RSS in Burkina Faso, we started doing that analysis. And from that analysis, we developed a curriculum in the collaboration with the IHI. We've trained several, I would say, profile. Here you can see we've trained people from the NMCP, we've trained people, 13 people from the district level, and also we trained people from the operational level. At the end of the training, we were able to actually train people in 100 places, and we were able actually also to do a pilot study where those trainees, 100, we give them all the equipment they needed, and then we run a kind of pilot for them to go in their side, collect mosquito, and package them and send them to the lab. And it was a very successful experience, which we want now to duplicate in all the other countries. We've done the same in Crete, where the center has actually hosted a PhD student, 3 master students, but also several trainees came from the different countries around Cameroon and was actually trained. And we always make sure to have a kind of gender balance whenever possible. This is one of the criteria that we really put forward whenever we are doing our training, making sure to have this gender balance and build this capacity among women. And the same also has been done in Tanzania. And the good thing in Tanzania was that they supported development of the district entomology training curriculum, which is now available for all our countries. And based on their need, we can select the modules that we want really to be actually using during our training. And also, they also hosted several PhD and master students coming from neighboring country, Uganda, Mozambique, to build the capacity in the region, because that was also one of our goals, setting up those regional centers of excellence, was to also support those countries with weaker capacity to come and be trained and be supported by our regional center of excellence. And then, as I said, based on the success of the phase 1 country, we now have scaled up this to several countries, DRC in the Central Africa, Nigeria in the Western Africa, and Mozambique and Uganda in the Eastern Africa. And so what we've started is kind of desktop review, and then identifying the needs. So we will be building surveillance capacity, building a system, providing tools, analytic skill, for entomologists at the NMCP, but also support this and make it sustainable by setting up continuous training, in-country training for medical entomologists as needed. We always go to the NMCP, we do the analysis, and then we come up with all our findings, and it's the NMCP deciding, okay, I'm almost done. And the genomic program, as I said, so based on the fact that we've seen that the capacity was lacking and most of the country was not able to select data, so we've got some countries and we collected mosquito, send it to Sanger and got them sampling. And through this process, we learned also what was the bottleneck and come up with solution later on. And based on that, we've seen that there was lacking capacity in terms of bioinformatic capacity to be able to do the analysis. And with Sanger, we've developed an online training with 8 workshops. And the first year, we were able to train 50s training. And this year was the second cohort with 100 training, and we received more than 8,000 applications. And to also support the country and develop really advanced skills, we at PAMCA have recruited 4 fellows, which are training of trainers, and we sent them to Sanger to really develop a deep capacity on this. They will be supporting the Regional Center of Excellence, but train people in different countries. The Women in Vector Control program came from the study that we've done, which identify really weakness in that fight with all these key or main, I would say, issue, gender disparity, gender discrimination, sexual harassment, and also not having policy. And we try to address all those issues, starting with the program and also implementing. And now we have regional coordinator in each of our regional center of excellence supporting our resources. And the outcome we want to have is have an African woman with capability, skill, technical knowledge, confidence, and support to access opportunity to advance their career in vector control, but also have them remain in that. And it's one of my programs that is really very active, participating to all the celebration that we are having over the day. Last but not least, our flagship is our annual conference, which we've been actually having since 9 years now. And the last one was in Ethiopia, where we had 850 attendees. And the next one is in Cote d'Ivoire, and we expect to see you all there to share a lesson. Thank you so much. And if you would like to have more information about PAMCA, you can scan this and you will be in our webpage and be able to get more information. Thank you so much.
Okay, thank you so much, Dr. Enhazi Amadou Yang, for so informative presentation and also beautiful, great platform, PAMA. Thanks so much. So we go to the last presentation in this morning. I would like to invite Dr. Miko Thomas, who will tell us about the vector control platform, how they work, Alliance for Malaria Prevention. So please, welcome.
Good morning, everybody. I hope you can hear me and you can see my screen.
Yes.
Firstly, thank you very much to APMEN for this invitation to present the Alliance for Malaria Prevention, or AMP for short. Secondly, I would like to apologize. I am looking over Mount Batur, which our Indonesian colleagues will know very well, and unfortunately has just started raining very heavily. So I do hope that there's not too much background noise and that you are able to hear me. So, okay, I just want to give you an overview of AMP. I am aware of the time limitations. So AMP, we really are a global partnership. We're housed and chaired by the International Federation of Red Cross and Red Crescent Societies, Federation for short. And we do focus on 3 core activities. The first being the coordination of partners, whether technical, implementing, or financial partners that are involved in the distribution of insecticide-treated nets, ITNs, whether through mass campaign distributions or continuous distribution channels. We also develop operational guidance that support or that help national malaria programs in the planning and in the implementation of their distribution. And we support national malaria programs and the implementing partners with technical assistance for planning and implementing their item distribution. This is really based on country requests. I'm really sorry, the rain has just come now and it's come very heavily. AMP is a core member of the RBM Partnership to End Malaria's Country Regional Support Partner Committee, CRSPC. So in the coordination of partners, we have core staff members, technical and administrative, that are housed by the Federation in Geneva. We also have the AMP Core Group, which is really our steering committee that monitors the AMP work plan and also ensures that our output meets our work plans. We have a weekly coordination call with partners, which I will provide you with a link afterwards, and hopefully you will be able to join. We do have working groups that are there to support the planning and support countries in filling the gaps in information and in learning, such as, for example, the newly created working group, Humanitarian and At-Risk Populations. These working groups are continuously evolving. So, for example, in 2019, we started the multi-product working group, as we just heard about the dual AI nets. But now that we've realized that most campaigns actually are a multi-product campaign, so it's just part of our normal support. We also have our annual partners meeting and the campaign digitalization meeting, which will be held in February of next year. Everyone is welcome to join the AMP partnership. If you want to join the AMP mailing list, you will have a link. You also have a link in this presentation to the AMP weekly call, which is held every Wednesday. We're always looking for country presentations on the weekly call. So if there's anything that you would like to share, lessons learned, any sort of challenges, specific challenges or innovations that you would like to present, then by all means, do please get in touch with Marcy or my colleagues, Marcy or Elisa, to present. The weekly calls are also a really great opportunity to find out what distributions are happening, where countries are distributing, campaigns that are being held, and to really just get an update on, not just an update on their activities, but also on their challenges and their successes as well. AMP, we do house the net mapping project, which does track all WHO pre-qualified approved ITN shipments from suppliers. We maintain the ITN campaign tracker, which feeds into the RBM update. Our challenge is that this tracker is really never up to date for campaigns that are from the Asia Pacific region. So we would really appreciate your assistance and support to make sure that this country information is correct, because it does feed into the World Malaria Report. So I don't know if you are able to find some appropriate points in each of the countries or in the region that is able to support us with ensuring that this information is up to date. Well, as I mentioned before, we develop and disseminate operational guidance. These are found on our AMP website. I really hope you can hear a little bit of what I'm saying, because it's really just pelting down rain here. So this operational guidance is developed, through extensive review. Actually, it's developed by AMC and the corporate community consultants and the staff. That it is reviewed from our partners who have extensive input in this kind of document to ensure consensus between the partnership amongst the different partners. That's also being informed by quality level. We do provide technical assistance. I'm so sorry that you can't hear me very well. It is it's probably this really, really bad rain. I'm so sorry. We do also provide technical assistance. To programs. We have been doing this for over 15 years, and we do based on national programs. The bulk of our support has been in the African region, which is where, and that's primarily due to malaria burden formed by African countries. As an example, in 2022, we did provide support to 22 countries, and that was through 9 different missions, whether people in countries or through remote support, distance support, and we have supported the development of the distribution of over approximately 190 million students. And as you can see, so particular assistance is primarily in the Africa region, but with some support to Haiti and Pakistan as well. And over 80% of TIA providers on our roster are from malaria endemic countries, which is fantastic to see because we are seeing that this is one of our objectives, which is to build capacity in the countries that we support is really working because the people that we are mentoring are now becoming technical assistance providers themselves. We provide support with classical expertise areas such as developing a strategy or the operations and the macro plans and micro plans, but also in the social behavior change, monitoring, evaluation, and lately digitalization, which has become a massive part of campaigning. We do provide support for English, French, and Portuguese as well. We can have a full TA for the typical model of technical assistance, and we can cover one or all the technical areas. So, for example, a country like Myanmar, we have to deal with complex operating environment, which affects all technical areas, such as logistics, as you've seen, and then might want a full package. Either by distance, in country, or an hybrid model approach, or potentially a light touch PA, which is, for example, a country like Indonesia, which is seeing some issues and some challenges with behavior in the Papua province. Might want to have specific support for just personally we have a change, and it's very time bound, and we are also able to support them. These two backstop, we do have a mechanism that ensures that also new TA providers or TA providers that are going out for the first time, we do have senior consultants that do supervise and what we call backstop is new TA providers. And to ensure quality and a standardization. And we also, everything, all outputs are reviewed by the senior staff and senior management to ensure quality standards. We do also do country exchange visits, so for example, in 2019, the National Program for Nigeria accompanied us to Sierra Leone to learn about microplanning and the microplanning that we recommend so that they could learn from this. We do have a lot of other operational learning and best practices that we have on our website, such as, for example, on digitalization and also waste management. when we have provided a link to our website, so you will be able to access these when we share with you our presentation. So I'll stop there, and I do thank you very much for your time. And I apologize for this unfortunately bad weather that we are having right now. Thank you.
Okay, thank you so much, Dr. Mercy Austin, and thank you for the very long-lasting platform. And we learned a lot from that. Thank you so much. And now I give to the panel.
Miko, if you can hear me, just from all of us, I think all of us really enjoyed your presentation. Fascinating, very informative, helpful information you shared with us. Thank you. We heard you above the heavy rainfall you kept referring to. I support rain. It brings life to farmers and their crops and to biodiversity. So don't criticize rain, be grateful. But thank you for your talk.
Not flood.
Not floods, no. So, dear colleagues, we've run out of time, very unfortunately, for the Q&A session. I don't want to relinquish the Q&A session. It's always very important. But the lunch arrangements with the hotel compel us to heed their time allocation. So I'm going to ask that we break for lunch. And if you don't mind, I know everybody is getting itchy pants and you want to leave, but please, let's reconvene. There's more information to share, more guidance that we're going to ask from you. So let's reconvene at 1 p.m., 55 minutes from now, for the Q&A session based on this morning's presentations. And then Dr. Mukhtar would like to lead a discussion on the PAMCA model, the RBM VCWG model, and others, of having work streams to expand the outputs and reaching out to the expertise available in the global community to help us provide stronger inputs and outputs for vector control in Asia Pacific by way of dedicated work streams. So we ask your help there. I have 3 quick announcements, if you don't mind. First of all, we've had a very generous offer from Dr. Tirapap, Professor Tirapap, and his team, who are organizing the Asia Pacific Conference on mosquito and vector control in Chiang Mai next week. It's a fairly major international conference with many top-level speakers. They are making a link available free of charge so that anyone who is interested to listen in remotely, you can access the meeting events. Wulan will send out by email the links that have been given to us so that anyone can listen in when you want to. It takes place next week, this meeting. I also referred yesterday before the meeting, and I would like to ask again, in front of you on the table, you will find a media consent form, if you wouldn't mind completing that form, which will allow us to make use of the photos that have been taken during the conference and distribute those photos via blog sites or media, etc., legally, if you don't mind. Also, for those persons that have been funded by APMEN, may I ask any receipts that you have or boarding passes? Receipts and boarding passes, please could you give it to either Wulan or Dr. Porn or Wulan, if you have anything to add, or to Popo, please, I see you have something to say. Please feel free to add. Okay. I've been asked, those with boarding passes or receipts, etc., please give it to Sam at the registration desk outside. Other than that, I hope you have a wonderful lunch, and let's reconvene at 1 p.m. Thank you so much. Hopefully you enjoyed a good lunch. Maybe some of you even had a little quick nap, power nap. And we're now having our final session. We start with a Q&A session, and then we're going to move to the discussion led by Dr. Mukhtar on the work streams. So I'm going to hand over to Dr. Mukhtar. Please, Dr. Mukhtar.
Thank you very much, and thank you all presenters for wonderful presentation. Definitely, when there are a good presentation, there are also some questions. So if anybody has some question to any presenter, please raise his and her hand and tell to which presenter your question. So anyway, so Dr. Tang, yeah, right? Question.
Okay. Good afternoon, and thank you for all the presentation and participant. I have the question for Dr. Ifla from Indonesia. So
There's a question for Indonesia.
yeah, so I saw you do MDA, but I'm not sure I'm really catch up. You do MDA with ACT and Prima Queen, so you do also Prima Queen. Okay, thank you.
Yes, Dr. Tan. So the drug administered is ICT, dihydroaromatoxin piperacin, for 3 days, according to adjusting to weight and age for 3 days. But we also give 1 doses of Primaquine, low dose Primaquine at the first day. Yeah, 3 rounds. Month 1, month 2, month 3, and we observe 1 week for the side effect. So they can report, so the community can report to the community cadres, or the community cadre visit their home for monitoring the side effect. It's 1 to 5%. So mostly mild. We don't see any moderate or even severe. Yeah, thank you.
Yeah. Oh, yes. Ronnie.
I don't have a microphone, so I try to speak up. First of all, congrats on the new laboratory in Pakistan. I'm looking very much forward to using it as well. My question is for you also in regards to... Thank you. In regards to the enormous upsurge that you had in malaria cases after the flooding in last year. Do you have any idea how much of that is attributed to this change in vector? How much can be attributed to the fact that people were displaced or had to sleep outside their houses for quite a long time, and how much could be ascribed to the breakdown of certain other services, both in health and also in provision of vector control?
Yeah, thank you very much. This is a wonderful question, and we are also facing this question from other people as well, because you know that when the flood was there, almost 30% total population, 30 million people have to live to the temporary shelters. In temporary shelter, unfortunately, we could not use a proper vector control intervention, because you know that is a big hall and there are 100 families are living there. If we give the bed net even, they can't install the bed net, because due to shortage of space. And even the people who are living in the temporary shelter, like the tents, they can't use the bed net, they can't use the IRS. So there was difficulty in the implementation of the vector control intervention. That's why we were, not totally, but we were in the hand of mercy. And that's why this year, again, this similar pattern of the malaria cases is still in Pakistan, that 3.1 million, 3.1 million cases in 2022, and till 30th of October, we have 2.6 million confirmed cases. And we are expecting another 1 million in November, because November is a peak transfer year. So just because of the use of the implementation of the vector control intervention, the malaria caseload is still on the same pattern. And honestly speaking, we as a national program are so expecting for another 2 or 3 years to become, to the situation to become normal. Otherwise, no, the plus point is that now the people have returned to their homes, and the government did a wonderful job, and they construct the homes for the poor people. That's why now they have this structure. That's why we are now planning a systematic campaign for IRS, because the community demand the IRS rather than the bednet, honestly speaking, because we are getting the bednet from the Global Fund support, but the community demanding the IRS more. And thanks to some partners and the government of Pakistan, now we are focusing the IRS more than use of the bednet. So, am I clear with your question?
Yes, thanks.
Yeah.
Thank you. My question is for Dr. Niang. Thank you so much for sharing on PACMA. I think it's a wonderful example of the multi-stakeholder collaboration in the vector ecosystem. How much is PACMA involved in or engaging with the ecosystem of players introducing the malaria vaccine in Africa, and sort of what's the conversation happening between the vector folks and the vaccination program folks?
Thank you. That's a very good question. And actually, as you see, we are having really multi-partnership and collaboration with all the key stakeholders. We are in the vector side, but we also think and try to work with those working on the parasite and also vaccine people. So we've started with the parasite people, with Africa CDC. And there are some discussions that we may have with people working on vaccine. And in some of our partners, we have those that are involved in the vaccine trial, which we are working with to learn from them. But yes, it's of course, we have really to integrate all the effort to be able to really achieve our goal. Hope that answered to your question. Thank you.
Yes, thank you.
This is Dr. Muhammad Shirajul Islam, working as a surveillance medical officer in Bangladesh. My question to Dr. Ong from Myanmar. First of all, I would like to thank for your nice presentation. I have a question that what insecticides is resistance to mosquito, especially in the bordering area of Bangladesh? And another thing that not included in your presentation, that is what's the current status of the drug resistance, antimalarial drug resistance in Myanmar? Thank you.
The insecticide in border area is pyrethrin. Yes. And drug resistance is ACT, artemisinin-based combination therapy, artemisinin resistant in Kaya and Tenindai region. Yes. Thanks.
So, Dr. Virak.
Yeah, thank you, Chair. I'm Virak from Cambodia. My question is to Dr. Faunas about the zoonotic malaria. In terms, you have mentioned about the elimination as a public health problem, but here in malaria, most likely people are talking about the interruption of transmissions. So I'm thinking whether the One Health approach would be a good approach to be considered to tackle this zoonotic malaria.
It's a comment or it's a question? Comment. Thank you.
No, excellent. Well, thanks very much for that point. I think that is an excellent point, and it's something that really needs to happen. So we haven't seen any trials to actually control the malaria transmission within the reservoir. So there is a research need to think about how we can actually manage that, and that really needs a One Health approach. So it certainly needs to involve wildlife and veterinary services as well. So I think there's some kind of key priorities that come up as future research needs, and that's certainly one of them. I think some of the other research needs are thinking about even what's driving transmission between macaques. We don't know a lot about the vectors that are driving wildlife transmission. So certainly there's a use for that approach. Thank you.
If there is no question, may I ask a question? One question?
Following that statement and question to Dr. Kimberly, because this macaque, I don't know in the other country, but macaque in Malaysia is protected. All animals in the jungle are protected by law. So for the time being, they are cannot be just simply mass treatment, drug therapy, MDA, cannot be done easily. So I don't know. Maybe from this consensus, maybe can some pushing factor to change the act of this country, Asia Pacific, so that we can move faster, so that the macaque is excluded from the act. Thank you.
I have also one question to my colleagues from Indonesia. In one slide, you showed the epidemiology situation of the Indonesia. You mentioned that in some district where the API is above 100, and you are using only LR and LSM. And there is another scenario where the API is more than 250, and you have only AMD, mass drug administration. Do you not have any room for the IRS, because if there's such high prevalence, the IRS can bring down the, in our experience, IRS can bring down the caseload when there is such a huge API. So what is the status of the IRS in your program?
Yeah, I think you referred to the IPI to above 250. So it's related with the high endemic district. And actually in other at the 9 districts, so we are doing the both actually for ITN, ARS as well. But only for the villages that we are implementing the pilot program, we focus on the MDA alone. So we not combine between the MDA and the IRS. But the resident, they have the BedNet already. So it's a part of like mass distribution. I think it's in the last berapa tahun yang lalu ya? 2 years ago. 2 years ago, we provide a mass distribution of BedNet to the high endemic district.
It is a 3 years ago that the BedNet has completed its effective life.
It's okay. This is true. That's why we are going to redistribute the new BedNet for next year and also for the next 2025. So yeah, thanks. Yeah.
So question from sir.
Boram Kamlam, Deputy Director of Simpe Lao. So I would like to interesting with the ecosystem, like eco-health, for vector control or vector surveillance. My country, we have not only buffalo or monkey, but we have to see to protect ourselves. So we have to lesson learn, maybe follow up that survey. Thank you very much.
Thank you very much for the question from the audience, but there are some questions from the online participants. So I request Dr. Liu to raise those questions.
Thank you, Dr. Mukhtar. So there's several questions from our online participants. It doesn't mean to say we're now finished with the in-person participants. Let's give our online participants opportunity, and then we can go back, back and forth. So the first question is to Kimberly from Jeffrey He, and I think you've already addressed this, but confirm, please. Do we know of any countries that have established criteria to validate that zoonotic malaria is no longer a public health problem? So criteria.
I think the answer to that is no. I don't know if anyone from Malaysia would like to comment. Maybe Dr. Tom, you have thought about it?
Thank you, Dr. Kimberly. I think there are some works that we actually are trying to do with Dr. Jeffrey. So that's why he posed that question to us. So actually the answer right now is actually we're in the preliminary stage, and we are hoping that there is some discussion that we can do with the GMP program in Geneva, because we're actually tasked to do a joint working group to discuss about this issue. Thank you much.
Thank you. So there's another question from Jeffrey. Jeffrey poses tough questions. Yeah, and this is addressed to Mike. Yeah. So Jeffrey is addressing your question about moving away from the previous strict guidelines, or not strict guidelines, but the guidelines from WHO recommendations for larval source management, that it should be limited to few fixed and findable. So if you advocate that we can expand larval source management now because of additional high-tech availability of additional tools such as drones. And his specific question, he gives a fairly substantial introduction. If the 3 Fs, few, fixed, and findable, is obsolete by current standards, what would it take to get the high-tech tools that you propounded?
So very quickly, I'm going to turn this over to El Haji in a second, because, excuse me, we're working on a paper with PAMCA to address this issue. Just very quickly, in Africa, there are 23, from what we know, there are 23 different larval source management projects in Africa. They're all separate without sharing information, SOPs, et cetera. There are tremendous technological advances in terms of remote sensing, in terms of targeting, in terms of mobile technologies for managing the LSM programs. I think we have some very good examples in Ghana, Sudan, well, previously in Sudan before the war, but Sudan and other places. And so the issue is, and this is like for APMEN as well, the issue is a platform to help countries share best practices. So that's one issue. And I'm going to turn this over to you in a second. The second issue is WHO pre-qualification has 23 different larvicides pre-qualified. In Africa, you can find maybe 2. You get Temafos, you get BTI, and that's about it. Private sector doesn't want to spend the money for a national registration because there's no market, and there's no market because there's no national registration. So we're working with IVCC to try to facilitate national registration of the full range of WHO pre-qualified products. So, and just finally, I could go on for too long about this, but we see larval source management as a major component of insecticide resistance management. Completely different modes of action, and especially as we move into urban malaria, as we move into arboviruses, Aedes in urban centers, we got to go for larval source management, and it's going to be up to PAMCA to show us how to get there.
Yeah, thank you. A very interesting question. And actually, we had a pre-conference meeting in Addis with GATE and PMI actually discussing this issue. And in that meeting, we had WHO, we had AMCA, and we have PLAMCA and several other key stakeholders. And the thing is, so that guidance, and most of you know Silas Majambe, right? The guidance need to be updated, actually, that one, on the larval source management. I think it's something like 30 years ago that it was developed. So, and things have changed. We have new technology, drone. When you say findable, we overcome that issue with drone. With drone, we can find them and we can access them. That was one of the issue. And the other thing was also, wherever malaria has been actually eradicated or eliminated, it was done through larval source management. And the AMCA experience was actually shared. And now what we are trying to do is to really discuss with WHO and have that guidance changes. And for that, they need data. They need a pilot study. And one of the things that we are advocating as PAMCA is for funders, because we had PMI and we had GATE, we want them actually to support that pilot study in Rwanda, in Madagascar. They're using drone to be able to track those. And we want to gather all those data to come up with those proof that it's effective. And last but not least, we are having issue with residual transmission. And the main reason for that is we are actually facing outdoor biting and outdoor resting mosquitoes. The tool that we have right now can't target those mosquitoes. And the only way you can is through larval source management or new technologies such as GenDrive. So those are the kind of advocacy we are doing as PAMCA, trying to push funders, including GATE and potentially Global Fund, to really support those countries that want really to implement larval source management. And I think we're going to be there.
Thank you for that excellent response, El Haji, and also Michael. I have another question from Jeffrey, and then I have another one. So the next question from Jeffrey is to Susanta and our Thailand colleagues. So Jeffrey points out here that in terms of the easternmost distribution of Anopheles stevensii is along the two localities along the Thai-Myanmar border region, and then another near Bangkok. So Jeffrey's question is, this is a bit of a speculation, what is the likelihood of Anopheles stevensii expanding its range, increasing density within Thailand, but maybe also moving over into Cambodia and Laos and so on? And should national authorities be concerned, and is targeted vector surveillance urgently needed? So maybe Dr. Preeti, if you, or someone, if someone is willing to take, maybe Susanta, you first.
Yes. You know, it is a very good question, and we all worried about African situations, but now in the, this Southeast Asia part, I think already stevensii is now reporting. I have a, colleague in PMI in Cambodia. He just asked me, sir, you tell me how PMI has given importance surveillance of stevensii. So he was asking how we will do the surveillance, and I just gave one guidelines how we will do that. The question is that this is the species, is invading along with Aedes. Very adaptive species.
Willan, can I ask you to get a microphone, please? Thank you. Sorry, Susanta.
So the thing is that wherever Aedes is giving the footprints, now stevensii also going along with them, because they share the both, breeding sites, breeding habitats. That is the major thing. The thing is that unfortunately till now we do not have any information anywhere except some Indian context that what variants are available, because 3 variants are there, mostly 2 I will talk, that is the type form and the mysorensis form. So they are actually, differently behave, and vectorial capacity also different. So that is, and we have to make that strategic action plan. There are many places, mysorensis are there, but no transmission potential. I think Dr. Mukhtar also can support me, because their lifespan, by the time it transmits the disease, their lifespan is shorter than that period. It cannot transmit, like, Anopheles subpictus. Their laboratory, if you do the testing and everything, but in reality, their lifespan is shorter, 10 days, within below the sporogenic cycle to complete. So these are certain factors I think we have to do the biological parameters in
Okay, thank you, Dr. Ghosh. So I'd like to ask our Thailand colleagues if they are giving any thought to Nafli Stevens Eye, or is it not perceived to be sufficient threat at this stage to divert resources to Stevens Eye? Like you, Dr. Ghosh, I've also been making contact with colleagues in Laos and Cambodia, but it seems the distribution stops here in Thailand.
Yes.
And even those records are historic.
Yes.
Quite a long time, many years ago.
Correct.
So any comment from our Thailand colleagues, or not important?
I heard from my teacher say that Stevens Eye have the spatial complex, and the Stevens Eye that we met in at the northern of Thailand is maybe not the vector. I think we have to study about the species complex before. Thank you.
Thank you so much. Here's a question for Timo from Australia, and I'm not sure if you're still online to respond. Can you please quantify the effectiveness of dual active ingredient nets compared to pyrethroid only or PBO nets? Tim, are you available, perhaps? No, apparently not. So here's another question from Jeffrey. Kasetsat University in Bangkok has recently offered an MSc fellowship to a successful applicant from Namibia. Unfortunately, the applicant did not respond or confirm his flight at the start of first semester. Last-minute attempts were made. Given the loss of this fellowship, we would appreciate your advice regarding the process of nomination of candidates from Africa. And the question is addressed to Dr. Haji. Are you aware of the situation, LIG? So it seems Kasetsat University, Prof. Tirapap, Charyan Viryapap, they made a MSc scholarship available. There were problems in the prospective candidate taking up that offer. So as PAMCA may be facilitating a process to find a replacement, that's how I understand the question. Do you know anything about that? All right. So, Jeffrey, if you're listening in, I think it sounds like maybe it's best to make direct contact with PAMCA and see if they can help to find, sorry, the last question from Jeffrey is, Miko, is the ITN campaign tracker capable of tracking the co-distribution of LLINs and IRS in some countries that have previously deployed this dual strategy? I know WHO doesn't like that, but some countries do that. Anybody, because I don't think Miko is available. Anybody want to venture?
Yeah.
Only LLINs, all right. Okay, so there's a hand raised here from Zia Hassan. Zia, please, do you want to vocally ask your question? I'm not sure if we can do that. Or put your, there we go. Hello, Mr. Hassan, good to see you from Pakistan.
Hello.
Please give us your question.
Thank you. It's clearly visible?
Yes, we can see you. Please go ahead with your question.
Yeah, thank you. Before start of my question, I would like to saying the APMEN team, the most experienced Dr. Leo and the Dr. Muhammad Mukhtar, most experienced and beautiful personalities in chairing this conference. Also many thanks to APMEN team, host team that inviting me in the last July, 3rd July to 14 July for the international conference in Indonesia. I learned a lot and deliver in my country innovative interventions. I learned from Indonesia and deliver in my country. So many thanks for participating and for inviting the APMEN. My question is that most of the insects have olfaction system mechanism. Olfaction system mechanism, we see the mosquito especially. In mosquito have strong sensory receptors. So in this situation, what kind of tool or intervention could you suggest in this situation? This is my question. Over to you.
Okay, thank you, Mr. Hassan. We appreciate your participation. So the question is, you're saying that mosquitoes have a well-developed olfactory system, and how can we use that perhaps as an intervention, some tool that targets that particular opportunity? Anybody want to, I suppose, the repellents?
Yeah, I can go ahead. I mean, first of all, DEET actually affects the olfaction system and basically confuses the mosquitoes. And then, of course, we have spatial repellents, which probably are acting on multiple levels, but we think olfaction is one of them. You know, they have a range of activities, from diverting mosquitoes to confusing them to actually killing them. And so there's probably some interaction with the olfactory system with some of these spatial repellents.
Thank you, John. So, Mr. Hassan, I think you've got one response there, and it relates to the use of repellents. Anybody else want to comment, perhaps?
Yeah, I think, there is strategy called push and pull.
Yeah.
That means there are lure and attract. I think Gates Foundation had some, funding few years back. So the thing is that now, unfortunately, whatever the strategies we have got, traps. Now WHO has come 2018 guidelines how to use the traps. So the trapping mechanism in many areas, it is shown to be like, holiday islands and all this having very effective. And I know the studies by Nordball and all these things. And I am now working, I saw that EcoBiotrap.
Yeah.
It is very good for surveillance, and wherever you have utilized, and especially Aedes-borne, disease like dengue and all, immediately the cases has crashed down.
Yeah.
Yeah. So I think some alternate tools we have to think of in a great way. And additionally, whatever we are having, I think push and pull methods, I think we should think of all these olfactory systems and mosquito attractant and all this. So it's a
Thank
thing
you,
to, and
Dr.
WHO
Ghosh.
should think in a big way.
Yeah, thank you for that. We are seriously running out of time, unfortunately. There's another meeting after this meeting. So I'm going to ask, I thank you everyone for your interest in responding to the questions. Dr. Mukhtar, over to you, please.
So thank you, Dr. Liu. And now we are going to our final session, which is a plenary discussion. Actually, this is the idea that we in an APMEN vector control working group, we have no subgroup. So as we have the subgroup like the Raulbeck malaria vector control, there's some other working group, there are different work stream as subgroups. And which actually the basic idea behind those subgroup is the better visibility, ownership, as well as responsibility, and also the active participation of the national programs. Because what we are discussing, what we are developing, what we are discussing over here, the end beneficiary is a national program. So that's why we want to have a subgroup in the rollback, in APMEN vector control working group, like with some subgroup like the cross-border malaria transmission, because there is also a very big issue that the intervention efficacy, outdoor biting. So we have suggested few names of the first we want to get the idea from the consensus from this working group that do we need a subgroup like the rollback malaria vector control working group. Secondly, we have suggested a few names, and I'm sure that there will be the slideshow will be there for pooling and if you have suggested some other name for the subgroup, so we want to have a 3 or 4 subgroups, and main responsibility will be given voluntarily to the national program. We would like to request the national program, they should take the leadership role in those subgroups as a volunteer, like a co-chair, so that currently we have 4 people in the vector control working group, APMEN vector, me, Dr. Leo, Volan, and Ko. We want to make bigger team so that there will be some volunteers who can run these subgroups. So this is the main idea behind this specialist subgroup. And first we want to get your consensus that do we need really this subgroup in this APMEN vector control working group. And then there are some suggested names for these subgroups, and you can also suggest some good name. So, and then we will ask some volunteers to take the leading role for that subgroup. And then after this exercise, maybe within a couple of 2 weeks, not more than 2 weeks, we will develop some TORs for each subgroup. And then we will decide how we can proceed with these subgroups and for this vector control working group. And definitely when we will finalize these things, next year annual meeting, we will have a very short presentation on the performance or the update from the each subgroup. Rather, we have only presentations. So this is the overall idea behind this plenary session. So over to Volan, can you display the slides? Yes, we have to go to again join this. So I think we can't wait the response of everyone. We can continue the next one. Because we have another meeting at 2:30. Yeah. Yes.
So I want to suggest whoever wants to continue, please feel free in the background, continue making inputs to the Slido. We welcome that. We encourage you to do so. We benefit from your participation. So thank you for that. But I think we need to continue with the discussion, Dr. Mukhtar.
Yeah. So the first consensus is that everybody agreed that we should have a subgroup. Good. And then these are the rating for the sequence of the different subgroups. So You can also suggest some other name if you have some better name other than these names. That will be mostly welcome. And for the people suggesting the name who are already have some responsibility, like me and Dr. Leo. And so I think we should have the volunteers from the program primarily, so that they can also have their own involvement from the program. Yes, the person from the National Media Program, excellent. Should give the assignment. Yeah, Volan, they are already with, they have responsibility, Mr. Furia. Dr. Iqbal, warmly welcome. Silas, excellent. So we will also listen from Dr. Iqbal, that is it. If he is agree, that I'm sure that.
Yeah, I would like to volunteer for the outdoor, for the forest goer.
Excellent.
Yeah.
I will volunteer for, LSM and innovations.
Excellent.
Yes. And that will include Stephen Sai. Yes.
Species.
No, I'm telling you.
Yeah.
First area is Stephen Sai.
Yeah.
Because LSM, APMEN, and this thing. So I volunteer that group.
Any other volunteers?
Not volunteering, but I think the PAMCA example of centers of excellence, because there are some universities who are really leading the charge technically in some of these areas, and I think you can reach out to them. But again, I think PAMCA has a very good model for centers of excellence for these things, so just to put that out there.
I think Dr. Hadji you have mentioned there are 7 excellent centers under PAMCA. You told in your talk there are 7 centers of excellence. 4.
So I will ask.
Yeah.
Oh, sorry.
Yeah. No, he was asking how many centers of excellence we have. We have 4 now, and we are targeting to have 2 more in the Southern Africa and the Northern Africa. Yeah.
So I just want to request that you can also send your name if you after the thinking that through email, because you have the name of this subgroup. And I would like to suggest that the person who has some better expertise, like outdoor transmission, who has climate change, who has some better understanding, particularly I'm very much interested in the cross-border collaboration, because there are so many countries who have a cross-border issue. The countries who have the issue, like the Bangladesh raised the question and with Myanmar. So I would like to request those countries should take the lead on that particular group. So please think over that, and you can send your name later on through email as well.
You can have this climate change. Yeah. Very good presentation. Yeah, you had very good presentations. Yeah.
So another volunteer? Yeah. So if we don't have any further discussion on this, because all the questions are completed? Yeah. Yeah.
I just want to get some clarification about the way forward, because I'm not sure how we take this forward. I'm very happy to hear that the collective wisdom suggests that there's benefit and advantage in having subgroups. That's wonderful. It seems that we've identified some thematic areas. So now it's a question. I don't think we had enough discussion. Are these the appropriate groups? Are there other groups people want? And if these are good groups, how do we find people that can populate or lead guide these particular groups. So off the cuff, my suggestion is that we can send out to the APMEN VCWG membership a summary of this discussion, and then point out that at least during this meeting, these groups were identified as potential groups. We invite our APMEN VCWG membership to comment whether they agree on these groups or which of these groups they agree with, and if they have any additional other thematic areas they would like to identify, and then also call for volunteers to participate in particular groups. And then once we've got people that have expressed interest in particular groups, we can contact those people and ask for a vote of who might be willing to be the kind of leader of that group. Does that sound reasonable?
Yeah. I think this is a more logical suggestion for way forward. So, yeah.
Currently, I am a task team member of Vector Control Working Group RBM, Anopheles defense invasion in Africa. So I know that now we have made 5, thrust areas on that group, and we are regularly meeting and how to support the program in Africa. That experience I can say is very
Excellent.
important. Yeah.
Dr. Mukhtar, I don't want to take over your role. I'm treading where angels fear to tread now, but I'm trying to. we need to wrap up. So if there are no further comments, I've just been asked. There's a post-conference evaluation poll. Wulan is going to put it up on the screen. It would be wonderful just to get some feedback from you as to your opinion on whether you feel it was a worthwhile conference. Just to give us a sense of, did we do okay? Or you get 0 out of 10, go home and don't bother organizing another one, something like that. But I just want to thank Dr. Tang, Dr. Mukhtar, for chairing, organizing this morning's session. It was, again, a very instructive, informative, enjoyable learning experience. Hopefully everyone felt that they benefited from the opportunity. I certainly thoroughly enjoyed it and learned many things. And interacting, what a wonderful opportunity to interact with a good number of different people. And thank you, everyone. So I'm going to hand over to Dr. Mukhtar to give some closing words, and I believe that Dr. Mukhtar is then going to hand over to our APALMA Chief Executive Officer, Dr. Sarthak Das, to end off the day. And may I just heartfelt thank you to all of you. It's a privilege having you here and to interact with many of you. Unfortunately, not enough time to interact with all of you. But it's truly been a great event for me, and I appreciate you being here. And I think everybody enjoyed the opportunity to mix with colleagues. So sincere thank you from all of us. May I also use this opportunity to thank Dr. Pon, Popo, Wulan, and Sam for a job well done. You worked very hard, and it's paid off. I think everyone agrees it was a great success. To all of those, thank you so much. Thank you, Dr. Mukhtar.
So I think Dr. Liu has made my job very easy. Yeah. So again, thank you very much, all of you, for your very professional discussion, very active participation, and definitely it's a very, very big honor and proud for me to be the chair of this vector control working group in this region. And that's why when I became the chair, I have some idea floated with my team, and everybody agreed that we should proceed. So it was a very good teamwork within the team. But today I would like to thanks from my core heart that thank you very much for all of you for your excellent participation, excellent feedback, excellent sharing of experience, particularly those who made a wonderful presentation. Every presentation has some new lesson, some new message for the other countries. So my very special thanks to particularly the presenters for their excellent presentation, and also all of you for your very active participation. Thank you very much. Now I request Dr. Das for the official closing of this meeting. Over to Dr. Das.
Sorry, thank you. You know, I won't make this very long, and it's hard to be at the end because I know I'm keeping people from whatever coffee they need in their weekend or the next meeting. But I wanted to say, as somebody who spends a fair bit of time in meetings, like many of you, and many meetings of many talented, brilliant people, there's something striking, even in one day, about the earnest engagement and the openness in this room, despite clearly the level of brilliance that exists. And I think that's remarkable. And I'm sure that it has something to do with the kind of people that are drawn to vector control, I guess. But I think also it's a testament to your leadership, Dr. Mukhtar, and Dr. Tang, Dr. Leo, thank you so much. And also thanks to Wulan, others who I haven't met from the team, and to Amita, who's not here, and to Pone as well for pulling this off, because it's quite a bit to do. I'm just going to do 3 things. One is to give a very quick recap, since the time was taken to put it together by some of our team. 2 is to talk a little bit about APLMA and APMEN, and 3 is some observations on the future. And so the key takeaways I take from this in terms of a recap is that there are 3 things within that. This prioritization of innovative tools for outdoor biting, the strengthening of capacity building in entomology, and the promotion of more collaborative approaches for vector control. I'm not going to go into any of the details on what those conclusions or at least suggestions are for directions, but you know, for us, and I'll come to the second part of APLMA and APMEN, most people may be aware, but APMEN came first, and it was at the UN General Assembly in 2008 when Kevin Rudd, who was then Prime Minister of Australia, brought up the issue of the need, largely because of drug resistance in the GMS. And it wasn't until several years later that this idea that it's fine and well to be getting together and exchanging, and it's critical to understand what new knowledge needs to be generated, how best practice can be shared, but where is the political will to end this disease? And we get to APLMA. And I think in the evolution, I took on the leadership of APLMA in 2020, and I think the evolution has been, from what I can see, is, you know, this may be an incorrect metaphor, but and one that we have to continue, I think, as APLMA to embody. As much as we technically host APMEN as the one who receives the funding and then helps to do the administrative functions through the 3 working groups, APMEN is, we're born out of APMEN. It's literally not just the foundation in terms of the science and the evidence, but it's our mother, if you will. That's one of the things that I think is actually true, because we're nowhere in advocacy without knowing what to advocate for. And that's why it's so important that we be able to continue to support this work. Having said that, our job is to certainly make sure that we can keep malaria visible. And politically visible is the means through which we help to marshal the kind of technical and financial resources that are needed to continue so that we can end malaria, which when you sit in a forum like this, it sounds somewhat challenging, to say the least. But I don't think that what we look at from a point of view of as what we do when we try to advocate is that when we compare this, I'll just draw this very specific example to work that I was involved with in Papua New Guinea for many years, 10 years on HIV. If Papua New Guinea can achieve the kind of coverage it did in access for caring for a chronic condition like HIV, even in some of the weakest parts of the country in terms of primary health care, then certainly malaria can be eliminated even in a place like that, which constitutes 86% of Wipro's burden of malaria. But that's just to illustrate that even, and you showed the data on Papua, I mean, despite all the challenges that exist, the narrative that certainly we continue to push is that if 42 countries in the world have done this, then there isn't, and we have examples of a country in this region that did it during a civil war, or one of the second most populous country in the world. We can argue about all the reasons why those things happen, but there are fundamental things that tell us that it's possible. And that's the story that we continually try to share, but grounded in the evidence of the key points that need to be advocated for. So the last thing I just want to say about the future and what we've been doing, you know, what does APMEN actually do? Well, as was mentioned several times, I mean, at the global level in the discourse, Asia Pacific is frequently left out. Asia Pacific now has 2 seats on the RBM board, and I can say that one of the things we're working on in the next year and a half is to figure out how to get the best representation from this region on the RBM board. The second piece is we've been invited to the last few Global Fund board meetings, which I think is a really important piece to this puzzle, given what we know are fiscal cliffs happening both in the greater Mekong region, but also, I think, declining revenues, well, declining sources of not revenues, but declining sources of funding from the Global Fund, given the uncertainty of the replenishment that is forthcoming and the need for continued resources. So sustainable financing is another critical area for us, and being able to think some of that through with the Global Fund is a role that APMEN can play. And then the last piece is, what about here? And, you know, in the region, and just as APMEN, I mean, for APMEN, it's 3 WHO regions, AMRO, Sierra, Wipro. For us to be able to think about what we can do as a regional voice, I'll be very honest, it's only going to be as strong as what we can do in countries. And so we're grateful for the fact that all of you who are part of country programs provide your leadership, your time, and your expertise to this. And the way in which we work is really by trying to find ways to support national programs that are relevant, targeted, but use that as an entree to the offices of heads of state. We've been building good relationships in a few countries, in terms of in Melanesia, Solomon Islands, Papua New Guinea. We're looking at strengthening our relationships. I was speaking with the Vice Minister in Indonesia and as well in India. So I'm happy to share more, but there's no way we can do what we do without all of you. And so thank you all very much for giving all your energy to this, and we'll try to see if we can be good, not just good partners, but I would say, you know, be worthy of the kind of work that you do and what we need to do in terms of advocacy. So thank you.
So I don't know what to say now. But let me thank Dr. Sartak Das for taking time out of his very busy schedule to come and join us here, and to each of you as well out of your busy schedules for being here. I've just been handed all these speaker gifts. So I think, Wulan or Dr. Pon, do you want to? Dr. Mukhtar, okay. Yes, I will announce the person, and maybe Sartak.
Yeah.
Sartak can hand it to the person, if you don't mind. Thank you. So the first person we would like to acknowledge with gratitude for giving us a very informative speech today is Dr. Kimberly Fornas. Thank you so much, Kimberly. It was great. Yeah, learning about all these zoonotic simian malarias and so on. So it's going to keep us busy for a few more years trying to fight simian malaria. The next one is Dr. Susanta Ghosh. Thank you for your presentation, Susanta. Very, very important issue. Nafli Stevensai, our African colleagues will confirm. This is a most serious issue. Dr. Mukhtar, sorry, you got a gift yesterday already, so we can. But thank you for giving us a second presentation. It's very instructive, learning about Anopheles pulcherimus and so on. Dr. Aung Aung Mew from Myanmar for informing us about the status of malaria in Myanmar. Very informative presentation. Thank you so much. Dr. Iqbal Ilyazar. Thank you, Dr. Iqbal. Yeah, thank you so much for update on the situation in Indonesia. And then all the way from Africa, my goodness, we really appreciate all the information you gave us and examples and the goodwill that you've demonstrated from PAMCA. Dr. El Haji Amadou Nyang, thank you so much, El Haji. You haven't seen the last of us, El Haji. We intend following up. And I believe that's all. Yeah. Okay. Dr. Tang, as chair, he didn't necessarily give a presentation, but he had a very important job to do. Thank you so much for your contribution, Dr. Tang. Thank you. Who else? Yes. Unfortunately, you have to comply, Dr. Sartak. Yes. I'm going to ask Dr. Mukhtar if you could hand just small token of appreciation to Dr. Das, Dr. Sartak Das. Yeah. All right, I think that concludes our proceedings. Again, sincere thank you, and we hope to see you next year, probably virtually. We wish you well in your travels back home. We wish you well in the very important work you do, and we look forward to continued collaboration and interaction with you. Sincere thank you to each of you.